Welcome everyone to day one of our 5-day Southwestern Sydney Local Health District Research Showcase. My name is Jesh George and I will be chairing this oral health session. I'm a professor of interprofessional oral health at the School of Nursing and Midwifery at Western Sydney University. I'm also the director of the Australian Centre for Integration of Oral Health, which is a national centre based at the Ingham Institute, with Southwestern Sydney Oral Health Services as one of our inaugural partners. Before we jump into the program, just a few housekeeping rules. So for those on site, the toilets are the top and at the bottom. Hopefully all of you have got the program photocopy, and there's another one-pager with a QR code for a workshop. For those online, we will be sharing that. Can I ask everyone to please keep their mobiles on silent, please? And as I said, online, we've actually muted all of you guys from here, but we will give you the opportunity to talk once the presentations are done. And if you have any issues, please send a message on the chat because we do have someone monitoring the online streaming. If you need to leave the room, if you don't mind going through the exit on the top, just to avoid distracting the presenters. As you can imagine, some of those presenting today are doing it for the first time, so it can be quite daunting. And what we're going to do is essentially, as we go through the presentations, we do have a very strict timeline. And so you're going to get, for those presenting, or majority of presenters are doing it for 5 minutes, you're going to get a warning sign saying you've got 2 minutes remaining. Right, and my colleague Agni was going to do that. Then you're going to have one saying 1 minute, and then a stop, thank you. All right. At that point, you have to stop because, like I said, we really need to run according to the schedule. And we're going to keep questions till the end of each session, not at the end of every presentation. All right. And lastly, refreshments will be right on the top there. All right. So without further ado, I'd like to first introduce Caitlin May Franks, who's going to do the acknowledgement of country. Thank you, Caitlin.
Hi all, I'd like to begin by acknowledging the traditional custodians of this land on which this meeting takes place on, and extend that respect to any Aboriginal people here today. Thank you.
Thank you, Caitlin. All right, so I'm just going to do a bit of introduction, and then I'm going to hand over to Associate Professor Ravi Srinivas, who's the Director of the Oral Health Services in Southwestern Sydney. So firstly, thank you again for attending the showcase, both in person and virtually. I know some of you have traveled about 2 hours to reach here, and some of you actually, have to go back very quickly. So thank you so much for that. Today is a wonderful opportunity to hear about some of the amazing oral health research work and quality improvement projects being undertaken in Southwestern Sydney. I've been associated with the LHD for the last 15 years, and I've seen how the oral health research has grown from strength to strength in our area. I think what is unique about the work we're doing here is that we're actually challenging the paradigm of dentistry and oral health by working very closely with the broader health workforce and consumers to co-design integrated models of care that are effective, sustainable, and cost-effective for health services. Dentistry has long been working in silos, and we are slowly but surely putting the mouth back in the body and making oral health everyone's business. It's actually very apt that we're having this showcase here at Campbelltown Hospital, because from my perspective, it actually all started here way back in 2008. At that time, we started a very small project here with the Oral Health Services and the midwifery unit manager, Sharon Ellis. And really, we wanted to see whether we could get midwives to start promoting oral health among pregnant women. And we called it the Midwifery Initiated Oral Health Program, or the MIO program. The MIO program has been going on for more than 10 years. And in that time, it has been successfully rolled out across various states in Australia and in many countries internationally, and has resulted in more than 30 publications alone from that project and more than $1 million in funding. A big milestone for us was last year, the World Health Organization recognized the MIO program and is using it as a case study internationally to show how best to integrate oral health into primary health care. So that's a program that started, very small project in Campbelltown Hospital, about in 2008. So to me, this was the start of a movement that led to the establishment of our national center with Western Sydney University to drive research translation and impact. As you will see today, we have a number of projects across the lifespan involving academics, clinicians, and students from various disciplines and universities, including the University of Sydney, the University of Wollongong, all with a common goal of improving the oral health and general health of our disadvantaged populations. So on that note, I hope you enjoy this diverse selections of presentations we have for you today, and I wish all the presenters the best of luck. Thank you. So I'd like to welcome Associate Professor Ravi Srinivas.
Thank you, Ajish. Can everyone hear me? Yep. So thank you. Good morning, everyone, and welcome to the oral health. Well, it's actually the health research health showcase, but it's the oral health session. Before we start, just want to pay my respects to the traditional owners of the lands on which we meet, and pay my respects to elders past and present, and also emerging. Just want to recognize any Aboriginal colleagues who are here. Really, research, one of the big key areas of research for Southwestern Sydney has been around the Aboriginal populations, and we have a lot of Aboriginal partners who have been contributing to it. So today's showcase is really a highlight or a culmination of the work we have done in collaboration between Oral Health Services and Western Sydney University, as well as University of Sydney over the last many years, which has looked at collaboration between academics, teaching, and research. The key focus for our research is really around population oral health. We have been choosing to focus on capacity building of health professionals. It's very unique that a lot of the research which is being done in Southwestern Sydney is done by people who have got no connection with oral health, meaning they are, like, for example, they got Paula, who is from a nursing background, and we had Ariana and Amy, who are from dietetics and podiatry backgrounds. So they were all from non-oral health backgrounds, but they actually chose to do research in oral health services, which is very unique. And I don't think we have had that in any other. And even Rebecca as well with the Karmas with speech pathology, for example. So really good to see that. So over the years, our collaborations have helped in building evidence, especially to inform and support new models of care. We've also informed policy. So we're quite surprised to actually see, or we're not surprised, but we were proud to see our paper getting cited in the New South Wales Oral Health Strategic Plan, which was a paper around palliative care and how we can develop the models of care around palliative, because there's a huge gap around palliative care awareness among both palliative care providers, but also dentists. So that was something which we have contributed to. Since 2015, we have had more than 90 peer-reviewed publications, along with numerous quality awards, both at the district, also at the New South Wales Health Awards. We have had a lot of PhD students have gone on to finish PhDs and who are actually now influencing how oral health is viewed in the general health context. And that leverages off our linkages with the WSU School of Nursing and Midwifery, which I must mention had the vision to support this program right from the start. We've also developed a lot of information sheets for patients. For example, there's one for diabetics, which we developed, which is a unique. There's also the eating disorders one, which we had developed as well. So there's a few unique patient information sheets which we have developed, which came out of this research program. We have attracted a lot of PhD students, and I think we are attracting a lot more PhD students from various disciplines to undertake priority projects within the district, because the district, we have got certain priority areas which link up with the district strategic plan and also the New South Wales Health strategic plan. So the research projects are driven by those plans. So every time someone comes and says, can I do this and can I do that? We got to look at alignment to our strategic plan priorities. Research is a very important part of our operations, as we want to make sure that our evidence, we are having clinical practice which is evidence-based. It's also important to note that we have done significant interdisciplinary cross-collaboration, and we have looked at making the final, we used to call it beds, taking research from the bench side to the bedside or the chair side, and that's exactly what we're looking at. So look, I hope you have an interesting day today. I hope the presentations meet your interest. There's a lot of, there's a CPD program around special needs dentistry with Dr. Malik. And also there's a lot of other research work which is going to be quite interesting for you. And so I wish you have a good, productive morning. And once again, thank you once again for coming and your participation both here and virtually. So good luck. Thank you.
Thank you, Ravi. All right, so our next segment is the keynote presentation. So we originally had Mr. Graham Liston, who is the Executive Director of the Center for Oral Strategy in the Ministry of Health, to do the keynote presentation. Unfortunately, he had to pull out at the last moment due to a family emergency. However, we are very fortunate, very, very fortunate to have Cara Clark from the Ministry of Health, who has so kindly agreed to step in and present on behalf of Graham. So thank you so much. Cara is a public health policy and program specialist with 10 years of experience in the Ministry of Health. She is currently the manager of oral health services and strategic planning at the Center for Oral Health Strategy and has worked in the oral health division for the last 4 years. She spent the majority of her early career working in immunization and communicable diseases branch, as well as spending time at the Australian Red Cross Blood Service. Cara has also spent time working overseas in Palau, where she developed policies to improve the country's preparedness for the sick passenger arrivals pre-COVID, and worked with WHO on the implementation of the international health regulations in Palau. So thank you, Cara. Welcome.
Thanks, Josh. Can everyone hear me? Okay, so as you can see, I'm definitely not Graham, so apologies for that. But I would like to start by acknowledging the traditional custodians of the lands that we're meeting on today and pay my respects to elders, past, present, and emerging, and any Aboriginal people here today. So as Ravi was just talking about, we launched our oral health strategic plan in February this year. This was a long work in progress, and we have aligned it with the overall New South Wales Health future health strategy. In our plan, we have 5 strategic directions: improving oral health wellness across the population, providing safe, high-quality, patient-centred care, delivering truly integrated care, enabling research, innovation, health technologies, and supporting and developing our workforce. So today we're just going to step through each of the strategic directions, and we'll go through a little bit more about what we're doing in each of these spaces. So the first strategic direction is improving oral health wellness across the population, which is really looking at the prevention and oral health promotion space. So what we're looking at is a little bit of a different approach, looking at 4 domains: prevention at scale, clinical prevention, social marketing, and targeting integrated programs. So in the prevention at scale space, generally it's a different branch within the ministry. So health protection or Centre for Population Health, who lead the intervention with cause input. So that's looking at water fluoridation, food policy, tobacco control. All of those programs majorly sit in another branch, and we provide extra input. So in the clinical prevention space, we're delivering, it's delivered by oral health clinicians. So it's using our branches input with obviously everyone in the LHDs. So looking at clinical preventive care, brief intervention, oral health education. So looking at the smoking and growth assessment interventions, as a whole. We are also looking at doing, we are doing some social marketing and using smart channels to provide educational information to oral hygiene practices. So that's us working with the ministry's strategic communications and engagement team to provide interactive and much more graphic design than what we can do. So that's definitely not where our skills lie. So it's supporting prevention at all levels. And finally, in this area, we're looking at targeted integrated programs. So working with other branches within the ministry, particularly for other priority populations. So people with disabilities, Aboriginal people, early childhood, healthy aging, refugees. So moving on to strategic direction 2, providing safe, high quality patient-centered care. So first of all, I would like to talk about how well we've done in the past year, 18 months. So at the moment, at the end of June, we had 95% of patients being seen within the recommended wait time, which is the best that the state has had on record. As you can see there, we've got 68,000 people that were waiting on the waiting list. I had a look this morning, and that's actually down to 58,000 people and 97%. So I think we're doing a very good job in that space. So I guess what we want to do now is we've gone a great way in particularly, so the peak we had at February 2022 was 43% of patients were out of waiting time because obviously we had a bit of a blowout over COVID. So where we want to go now is we want to focus on maintaining that on-time performance, and we have a really big focus on reducing the wait for specialist care. Recently, the Centre for Oral Health Strategy attended a Stolen Generations Survivors workshop that the ministry put on. At this meeting, the Chief Health Officer, Kerry Chant, announced that Stolen Generation survivors would have priority access to dental care. So at the moment, we're working with the Centre for Aboriginal Health to develop a kind of robust process on how that will work and how we can make sure that we get as many survivors as possible into that program. So we also want to prioritize. We also want to focus on prioritizing access to services at the moment. We are working with one of my team members is working on the priority oral health program and waiting list management policy, and we want to capitalize on all of those gains that we've made in the past year. So we are working on developing a new priority oral health program, and we're just in the consultation phase at the moment. And also we are working on improving access, obviously, to specialist services over the next year as well. So strategic direction 3 is delivering truly integrated care. How suitable are dental settings for engagement with priority populations? So I'm not sure if you know, but we provide, across the state, we provide approximately 800,000 episodes of care to over 300,000 people each year. So approximately 2/3 of these services are provided for non-urgent care for which patients are sitting on a waiting list. We know people will be coming in advance, and we have the opportunity to pre-screen through the triage questionnaire and by contacting patients sitting on those waiting lists. So many, obviously, as you are aware, many of dental courses of care require multiple visits over a predictable schedule, creating great opportunities for repeat engagement and for us to engage with them on the while they're on the waiting list. So what are we currently doing in this space? Currently, as I'm sure you're aware, we provide routine growth assessments to children who are accessing public oral health services, have their height and weight measured. This is something we work in collaboration with the Centre for Population Health on. Another area, we work with the Centre for Population Health and also the Cancer Institute, is smoking and vaping cessation. And that is going quite well. This is where dentists provide chairside intervention and may refer to the quick line. We are also working with on refugee and asylum seekers and improving initial screening processes and access to dental care for these patients, and incorporating trauma-informed care. So this is something we're working with health and social policy on. The Aboriginal oral health team who sit in my team, they do health promotion work, particularly for NAIDOC. This year, the theme was for our elders, and we work quite closely with the Centre for Aboriginal Health on all of our Aboriginal oral health programs. We also fund the New South Wales, the ADA New South Wales Filling the Gap program. Partly, we provide some funding, some admin support funding, which provides dental care for people who otherwise might fall through the gaps. We're also undertaking a big review on teledentistry at the present time, and working out how best to increase the use of teledentistry and how to improve patient experience and reduce waiting times. And Western New South Wales are currently undertaking a waiting list management pilot. So they're using teledentistry and updated triage questions to reduce waiting times and provide care that's closer to home. It's also kind of getting rid of some of the assessment wait lists that we have. So where do we want to go from here? We want to be, what more can we do with referral pathways? So we're currently working with alcohol and other drugs for opportunities to integrate further with oral health. We are working with domestic violence, so prevention against and response to violence, abuse and neglect. So Sydney Dental Hospital is doing a pilot with for domestic violence victims. We are also working with mental health, focus on young people and the impact of various prescribed medications. So what other opportunities are there? So we have opportunistic interactions at public dental clinics. So South Eastern Sydney is looking at blood-borne virus screening in waiting rooms. We have oral health advice at pharmacy and GPs, supported education programs, and also midwife-led clinics, oral health assessment and referral for the mother and child. And also looking at Aboriginal oral health access, improvement and partnering with Aboriginal community-controlled health organisations. Strategic Direction 4. This is about enabling research, innovation and health technologies. So how do we improve this area? So some of the things we're doing at the moment are we are fostering partnerships between local health districts, universities, professional bodies and COS. We have a oral health research committee that sits twice a year, and everyone shares the research projects that they're working on. We have been heavily trying to push for the targeted call for research at the NH and MRC to be for dental. We nearly got there. We got there to New South Wales to put that in, but unfortunately it didn't get up as a whole for the national. And we're also working towards a data request process. So the Oral Health Information Systems team is, we're working together with them to provide what's called a data lake, so that people can request specific data, and we can have a robust process around that. So in the innovation space, we are continuing to ask the questions, why do we do it like that? What if we changed it? And how can we improve the patient and provider experience? So they're kind of some of our key things that we're thinking about in our branch. And on the technology front, we are implementing a new contact center software across the state, which is nearly complete, I think. We're looking at online interactions and the use of teledentistry, as I talked about earlier. And we are also looking at infrastructure and how we can better improve our infrastructure across the state. Strategic Direction 5 is supporting and developing our workforce. Some of the work we are doing on recruitment and retention at the moment, we have strategies that we're working with Ministry Workforce on. So we are developing a website portal for people who are interested in working in New South Wales public dental services. We are developing resources, so flyers, videos, and to promote why New South Wales Health is a great place to work. We are in the process of getting approval for an overseas recruitment strategy. We have a booth at the upcoming FDI conference to try and entice people to come and work for us. And we're working very closely with Ministry Workforce on incentives and how we can, I guess, make New South Wales Health a better place to work. We are also working with, or partnering with universities to develop and enhance career pathways for Aboriginal people. And every year we have, we're improving the capability of our current workforce and ensuring practitioners are working to their full scope of practice. So I'm not sure if you are aware, but we do have a capability development program that we run every year that you are more than welcome to apply for. So finally, what is your role in all of this? Get involved in research and innovation in your LHD. Apply to the capability development program to increase your skills and improve the scope of care you can provide. Continue linking patients with other services and programs such as Quitline, healthy eating and active living. Speak up if you think there are opportunities for integrated care that are missing, that we haven't thought of yet. And encourage your friends to think about the public dental service for their career. Thank you. Does anyone have any questions? Yeah, I go.
Yeah, sorry to put you on the spot, but
that's okay.
But maybe for the people online. Thanks, Cara. Very interesting. I don't want to put you too much on the spot, but I have a question around these overseas recruitment strategies, and we as an institution struggle about this too, obviously finding enough workforce. You might be aware that in UK they're talking now a lot about payments back to the countries, especially low and middle income countries from which we recruit health workforce, which is desperately needed there too and was trained there for grants and other schemes. So have you thought about this, how you will navigate this from an ethical moral perspective to hire workforce from low and middle income countries towards New South Wales?
At the moment, we're focusing on New Zealand because they have reciprocal arrangements and obviously the visa situation is a lot easier. We're focusing there first and then we're going to look at going to other countries after that. So that's, I guess, our first step and getting that approved to start with, and then looking at, maybe England, Canada, other countries that have more reciprocal arrangements, because particularly around the visa situation, because obviously that's the visas is not something that us, New South Wales as a government, can probably influence very much. So looking at those kind of countries first. Yep. Development programs? Yeah, sure. So we run a capability development program. It is where we have, I guess, a bunch of money where we can provide, what we want to do is increase and improve people's skills and scope of practice. So you can apply to different courses. Generally, it's a course that may be useful to increase the scope in your LHD specifically. You can nominate for any course that you would like, as long as it aligns with your LHD's, I guess, strategy and plan, and it has to have so it has to have Ravi's approval, and as long as it's increasing the ability of you to provide services. That's okay? Anything else?
There's no questions online.
No questions online? Great.
Awesome. Thank you so much. Thank you, Cara. Again, a big thanks. Like I said, she stepped in. Friday night, she found out that she had to come all the way here, and she has to leave because she's conducting interviews. So I guess from my point of view, I think it was wonderful to see this year when the strategic plan came out that integrated care was mentioned, and there was a specific mention about nursing, allied health. Having been trying over the last 15 years, trying to push that agenda. It was always a struggle. And I know my own colleagues, Paula, whenever we go to new settings, and if it's a nurse leading that or an allied health person, there was always a challenge, like, what's happening. But now you've got the strategic plan to back you, which is amazing. And I think we are lucky to be in a state like New South Wales because it's not just integration from the non-dental. So as we know, the dental profession has been asked to do more and more, broader things like height and weight. And we are the only state in the whole of the country where public dental services are doing height and weight. So, so I think, when you speak to other states, they're always asking, how did this happen? Who started? So, we're really good. It's great that we have a very proactive, I guess, health services and policymakers. All right. So the good thing, guys, is that we are actually running a bit early. So we may not necessarily have that stop sign coming up, but let's see. We'll see how we go. We may give a bit more time during the morning tea for a bit more networking. What I'll do is I'll also switch on the mic for the online presenters because there is an online presentation, the second presenter here. But what I would ask everyone to do is we really need to make sure that everyone has an opportunity to answer questions. So in your mind, think of questions with each presenter. And at the end, I know the presenters probably don't like it, but it's good experience. So at the end, I'm going to ask all the presenters to come to the front and we will pose the questions to you. And that goes to the online guys as well. If there's a question, you could either pose it as a chat or you can actually unmute yourself and ask a question. So let me just open the next session slides. Can I just ask online, everyone is happy with the slides? You can hear us and everything is clear? Can you give us a thumbs up or whatever? Okay, good. Thank you. All right. So our next session is called Co-Designing Models of Care. And our first presenter is Paula Sanchez, who's from the School of Nursing and Midwifery at WSU. Just to plug in that Paula is one of our first PhD students at our center to have graduated a few years ago in the integrated oral health space. So welcome, Paula.
Don't run the time yet. Are you okay with the light or is it a bit dark for you? You don't feel like sleeping or anything? No? I thought it was a little bit dark. Anyway, so hello everybody. So thank you, and your time starts whenever. Yeah. So yeah. Just move here. So do you know that cardiovascular disease is the leading cause of death in the world? And do you also know that in Australia, one person dies of cardiovascular disease every 12 minutes? And And I'm sure many of you from the dental areas know, and now know a lot more, that or periodontal disease or gum disease is associated with cardiovascular disease. There's a strong connection there. As a result of that, cardiac care clinicians have been recommended that they need to incorporate oral health into the setting. However, in Australia, there is lack of a simple, valid, and reliable oral health screening tool to help cardiac clinicians screen the patients with cardiovascular disease at risk of having oral health diseases. Once identified, these patients can be referred to appropriate dental services. Administering such tool by clinicians in the cardiac setting can be challenging due to time constraints. Therefore, it's necessary to have an oral health screening tool that is reliable, short, and easy to use. I'd like to introduce myself as well, saying that this is part of the beginning of I started this earlier during my PhD. So it's part of a bigger project of study. So the aim of this study was to develop and validate a simple oral health screening tool for cardiac care clinicians. After an extensive review of the literature to identify the items, and after piloting the tool with patients, a 4-item tool was developed by an expert panel. You can see the tool there. So the tool incorporates 4 very important areas that have been researched that are predictors of problems with oral health. And we use a specific one for cardiac patients, basically bleeding, swelling, gums, sensitive teeth, loose teeth. The second one is in relation to seeing the dentist in the last 12 months. The next one is about smoking. And the last one is about whether patients have dry mouth, and dry mouth specifically because many cardiac medications cause dry mouth and other oral health problems. This tool was then piloted through via a cross-sectional survey, including a total of 319 patients with cardiovascular disease attending Sydney Local Health District. And this happened during December, July, and January this year. During the survey, participants completed the 4-item tool that you just saw. And that was tested against 2 gold standard tools. The first tool was the OHIP that you may all know, the OHIP tool, which is the Oral Health Impact Profile, very well known and validated worldwide, and a clinical oral health assessment, which was conducted by trained dental clinicians from Sydney University, supervised by a dentist from there as well. The mean age of patients was around 60, and the majority were men, which is consistent with the population of people with cardiovascular disease in Australia. The majority are men. Even though, as a result, the tool resulted in relatively low specificity, the 4-item tool had high sensitivity for correctly detecting those people with CVD at risk of having oral health problems. When the tool was compared with the OHIP 14 tool, the clinical oral assessment, higher sensitive was achieved, and achieving up to 88%. So in conclusion, the study resulted in the development of a simple cardiovascular oral health screening tool for healthcare providers that is sensitive to identifying people with cardiovascular disease at risk of poor oral health, requiring dental referral. This simple and accessible tool that cardiac care providers can incorporate into their routine practice has the potential to be transferable to various cardiac care settings. Thank you very much. And this is the team with some of the dental students that were supporting as well as a student from Wollongong University. So thank you very much.
Thank you, Paula. And I think Paula's study was a really good example of a whole bunch of universities collaborating together with health services. So, involving Southwestern Sydney, University of Sydney and Wollongong. I'm actually just going to see if I can switch on the audio for is Rishab and Abhinay there?
Yes, we're here.
Okay, so yours already audio set. Okay. Both of you there? Rishab?
Yes.
Okay, cool. All right. Because I'm managing your slides, just tell me when to change, all right? Just say just change slides, all right?
Sure thing.
Okay, so.
Thank you.
All right, so our next presenters are two medical students who are doing this project as part of their degree. So Rishab and Abhinay are going to be doing a joint presentation. So over to you.
Thank you. So our presentation is on the Cardio OH GP program. So it's about promoting oral health among patients with cardiovascular disease in a general practice setting. So for this one, it's a scoping review. Could I get the next slide, please? Okay, so for the background, as Paula mentioned before, cardiovascular disease places a significant burden on the Australian healthcare system, as it is the leading cause of death in Australia and around the world. And there are some very frightening statistics with cardiovascular disease. Okay, and it's also very strongly established in the literature that oral conditions are strongly positively associated with CVD. But the exact mechanism of this relationship has not been established. So, and also GPs and other primary care providers, which are for a lot of Australian patients, their first point of care, can play an essential role in managing the oral health of their patients that have cardiovascular disease to improve their health outcomes for both of these conditions. Could I get the next slide? All right. So our aims for this scoping review, we kind of had two main questions we wanted to answer. So we wanted to scope the existing literature, and we wanted answers to what is the current evidence on the role that GPs play in managing the oral health care of patients with cardiovascular disease. So currently, what do GPs do to help manage the oral health care of cardiovascular disease patients? And also, what resources and guidelines are available for general practitioners to use to manage this oral health care of patients in the context of cardiovascular disease? Next slide, please. All right, so for this scoping review, we followed the JBI scoping review methodology. We searched 4 peer-reviewed databases, so Medline Ovid, Medline Embase, Biomed Central, and CINAHL for questions 1 and 2. And for research question 2 specifically, the resources and guidelines that are available to GPs, we also extracted gray literature from the internet, okay? And so, yeah, our search terms related to oral health, cardiac health, general practitioner, managing, and resources, okay? So all the sources we identified were subject to a title and abstract screening using the following things. So they had to be available in English and had to be published in the last 10 years. And there had to be peer-reviewed papers that described primary research. And so we included systematic reviews and meta-analyses for these as well, okay? And then a secondary full text screen was also done by 3 reviewers to determine which sources had the relevant data regarding the review questions. And then the data extraction has now been fully completed and the critical analysis is still underway. All right, I'll hand it over to Abhinay now.
Yep, so in terms of for both research questions 1 and 2, we identified 4 peer-reviewed papers. So these were from Australia, China, France, and USA. 2 followed on the research question 1. So this included a case control and a cross-sectional study, and then 2 peer-reviewed papers for research question 2. So another cross-sectional and a cohort study, along with 6 grey literature sources, predominantly in Australia, but also including Malaysia and Europe. So for research question 1, which as a reminder, was focusing on GPs and their role in oral healthcare. We found very minimal evidence suggesting GPs do currently play a role, particularly within Australia, in terms of managing oral healthcare in their patients with CVD. And for our results, a majority of them were looking at research question 2, which was focusing on those resources and guidelines which are supporting GPs in managing oral health. So in general,
Sorry,
from
can
our
we
results,
just get the next slide? Can we just get the next slide, please?
Sorry.
So Ajesh, back to the results. Thank you. So in terms of the results for research question 2, we found that the general practitioners do not receive sufficient training in oral healthcare under the current systems. And looking at the clinical guidelines, we did run an international search. However, majority of our results were looking at Australian clinical guidelines in, for example, in the Royal Australian College of General Practitioners and also Heart Foundation Australia. But we found that there was very minimal reference to the relationship between oral health and cardiovascular health, and any information that was contained focused predominantly on the relationship between oral health and rheumatic heart disease, rather than other relationships that are well established in literature. And finally, we found that the evidence showed an overwhelming lack of reference to the importance of involving oral healthcare specialists, such as dentists, in the care of patients with periodontal and cardiovascular disease. Next slide, please. So in terms of the implications of our research, we very much agree that further research is needed to explore how oral health management can be incorporated in the GP setting to help manage patients with cardiovascular disease. And there needs to be a lot of emphasis on improving guidelines and oral health resources to support GPs in the management of cardiovascular disease and oral health care, which is one of the things that this project is focusing on in the later stages. And finally, we do need to try to get more funding into oral health to help incentivize GPs to help them with their practice and include oral health care management. Thank you.
Thank you, Abhinay and Rishab. So we've passed the IT litmus test. That was one of the, it's always a challenge, and it worked. So thank God for that. Hope you guys are going to hang around for the question time, Rishab and Abhinay.
Yeah, I'll try to hang along as
Will you
much
be
as I
around?
can.
Okay, if you're around, all right, we'll see. Thank you. Our next presenter is Namita Thomas, who is a PhD student. She's actually an overseas trained dentist who came about a year ago to embark on her PhD journey. So welcome, Namita.
So good morning, everyone. I'm Namita Thomas. First of all, thanking my supervisors for their constant support and guidance. Coming to my topic, that is reviewing current evidence around oral health care among women in perimenopause and menopause. Thank you. So women in menopause are at high risk of developing oral health problems like dry mouth, burning sensation, altered taste sensation. So all these affect the overall quality of their life. So various studies have shown that the healthcare providers could play a key role in promoting oral healthcare among women across various phases of their life, like pregnancy, menstrual cycle. However, no comprehensive review have addressed the oral health needs of women, the practices of healthcare providers, and the relevant supportive strategies. Therefore, the aim of my study is to explore the oral health knowledge, attitudes, and practices of women in perimenopause or menopause, their healthcare providers to inform strategies for oral health promotion in Australia. So coming to my methodology, the protocol is registered in Prospero. Based on the search strategy as well as the eligibility criteria, the articles were searched across 5 different databases. The screening as well as the data extraction was done using the Covident software, and a thematic synthesis approach was done to develop the themes and subthemes. So the quality assessment for the cross-sectional studies was conducted using the JBI checklist, and for the guidelines, the AGRI2 instrument was used. So the key findings of the review. So only 12 articles were identified from 557 studies, which indicates that limited studies in this particular area of practice, low quality articles, and majority were from developing nations. So 8 studies were relevant to women. So the findings indicate that overall there is low awareness among women related to oral health changes associated with menopause. There is poor attitude, or like there is mixed attitude among women related to the importance of dental visits and the importance of dental care. So, and about practices, there is poor practices among women related to various oral hygiene measures. Related to healthcare providers, only 3 articles were identified in this area. Even though the healthcare providers had adequate knowledge related to oral health changes associated with menopause, there were poor attitude related to various treatment strategies, as well as poor practices in advising patients related to various oral health changes associated with menopause. So coming to the last, that is guidelines, only one guideline that is developed in this particular area of practice, and that was from United States. And this was mainly for the recommendation for clinicians. So coming to my last slide. So overall, there's very little information globally and absolutely nothing from Australia. So the low awareness among women in perimenopause and menopause, the poor practices and attitudes of healthcare providers, the insufficient guidelines reflected negatively in the practices of women. And this is one of the first study to address this, and it's a part of my PhD program. Therefore, this study has implications for research, policy, and practices. That is, more study in this particular area is required with better quality of articles, more training programs that can support healthcare providers, as well as more awareness program to address the oral health needs of women is therefore essential. Thank you.
Spot on, Namita. Well done. All right. Everyone's doing well with time, so that's great. So our next presenter is Jacqueline Rojo, who's a lecturer in the School of Nursing Midwifery at Western University. I guess for me personally, I think this is a very important project because really to start changing culture and practices in particular the nursing midwifery workplace, it's important to start at the undergraduate level. So welcome, Rosa.
Thank you, Ajesh.
Can I get you guys to, okay. All right.
Finish 12:30.
People online, do you mind just muting, please? We can hear you.
Thank you, Ajesh, and thank you, everyone. It's a pleasure to be here today to talk to you about an exciting project that's happening in the School of Nursing and Midwifery at Western Sydney University. This is actually my PhD project, which is looking at integrating oral health care in the undergraduate nursing curriculum. And what I'm going to present to you today is a component of that, which is the project, which is a study that we ran, which was looking at co-designing an oral healthcare educational intervention for undergraduate nursing students. And the exciting thing about this project is that it's an Australian first, and we're really pioneering this. So I'm really excited about this. So just to begin, 3.5 billion people worldwide are affected by oral disease. So this is actually quite a significant disease burden. And we know that the role of dental screening and health promotion is changing, with nurses being able to play more of a key role in the screening and in this space. However, in nursing, oral care is often perceived as less important. So that's an area that is in need of change, which leads to my project. And the aim of this study was to develop and co-design an oral health care educational intervention for nursing students and evaluate the process. So we also wanted to evaluate the co-design process as well. We used a 6-step co-design process as outlined by Dietrich et al. Our participants, we had 8 participants in total. We had second year nursing students and academic staff. We conducted 2 co-design workshops on Zoom, and they were just over an hour long each. We evaluated the co-design process and used a hybrid content analysis to analyse our data. But this is the exciting part. This is what we did. This is what we co-designed. So we the education ran across 2 subjects, a theoretical subject and a practical subject. The theoretical subject was focused on chronic disease and disability. And we honed in on the bidirectional link between periodontitis and type 2 diabetes. And this is where this was the focus of our education. So we developed the learning activities. We co-designed the learning activities based on Mesereau's transformative learning theory as the underpinning learning theory that framework this. We developed 2 subject matter expert podcasts. One was on periodontitis and type 2 diabetes, and the other was on how to make a dental referral, which was delivered in the practical subject. We also had a dental model, which, as you can see there on the picture, was it displayed various different pathologies, which was a good visual cue for the students. And we also developed a picture guide which outlined various oral health conditions and explained what to look out for. We did this alongside using the oral health assessment tool, and students were encouraged to attend to an oral health assessment during the practical class. So with regards to the co-design evaluation component of it, it was a very successful outcome. We were able to develop this intervention. It was comprehensive. We did evaluate the format of that 6-step co-design process. The students did identify that perhaps they wouldn't have liked to have be in the same workshop as the staff, only because if there had been bad blood or something, but between staff and students, that could have affected their participation. But that didn't happen luckily that didn't happen in our workshop, so that was good. But that was a message to go home with. The Zoom convenience was very important and promoted participation. And category 5, robust discussions. Everyone was given a chance to speak, so facilitation was definitely a big component of the co-design process, making sure that everyone had an equal voice. Now, this process, like I said, was very successful, and we're in the process now of evaluating that intervention. It has been implemented. It was implemented not long ago, and we're in the process of evaluating that now. So thank you.
Thank you, Jacqueline. All right, the last presenter for this session is Tiffany Patterson-Norrie, who is also a PhD student in the last few months. She's actually aiming to submit by December. Thank you, Tiffany, for coming. Tiffany's just recently had a baby, so she's managed to feed the baby and come to do the presentation.
Morning, everyone. So eating disorders have been increasing in magnitude and prevalence over the last few decades. Specifically, 1 in 8 individuals may experience a mental health condition at any given time in their lifetime, with a lot of them being anxiety and depressive conditions. In Australia, approximately 1 million of them are suffering with an eating disorder. However, we know that these statistics might actually be more significant than this. So individuals with an eating disorder are 5 times at risk of developing an oral health issue. So this might include dental caries or dental erosion. However, this in the compass of all the other symptoms that they're experiencing, including things like cardiorespiratory issues, issues with their reproductive system, often oral health might find its way down to the bottom of that priority list. However, in addition to that, they're also less likely to engage in oral health services. So whether that be out of fear or embarrassment or anxiety, or due to things like cost, they'll be less likely to actually go and engage in the oral health service. So by way of looking into this and mitigating this, we're looking at the role of non-dental health professionals. However, minimal literature exists exploring the experiences of these people and how they experience their oral health conditions. So to do this, we investigate the perceptions and needs of individuals living with a lived experience of an eating disorder regarding their oral health, specifically to have a look at what were their experiences of the oral health issues that they had, and what kind of resources would they like and perhaps want to see when they're in the clinical setting. So to do this, we used a qualitative study and we recruited individuals with a lived experience of an eating disorder. So to do this, we actually got in contact with the Butterfly Lived Experience Collective and recruited from them. And they generally have a pool of participants that have either had experience with an eating disorder or a body image issue. So we recruited from them and we did semi-structured interviews and then performed a hybrid thematic analysis. So in terms of the demographic of participants, 12 females participated in the semi-structured interviews. They had a mean age of 36.9 years. 15.5 years experience was the average of having an eating disorder, and we had varying types of eating disorders. And all participants who participated had a tertiary qualification. So the major themes are outlined as on the slide. So experiences and awareness of eating disorder related oral health. So what did they have as like their main experiences, including some of the facilitators to oral health, barriers and challenges, and then a suggested model of care. So in terms of their experiences, a lot of the participants, in fact, all of them actually had some kind of oral health symptoms that they experienced, whether that be erosion or sensitivity, and it all significantly impacted their quality of life. And as you can see in the second quote there, the person says it affected your overall health and quality of life. In addition to that, it impacted things like going on social outings, not wanting to smile and show their teeth. That was a really significant theme that kept coming back up. That it was really affecting the way people went about and lived their life. But in saying that, in terms of how it made them feel like in terms of facilitators, they were very committed to being physically well and recognized that oral health was actually a part of that. So in terms of taking care of their oral health and managing their oral hygiene, they were actually motivated and committed to doing that. And part of that was in terms of wanting to maintain an aesthetic and have a pleasing smile. Some of them were scared into doing it because they were worried that their teeth might fall out, and that was a scary thing. But it was good to see that they were actually motivated to want to take care of their oral health. Another thing that was actually a good facilitator for them was the fact that those that had gone and seen a dentist had a really positive experience. And that was a finding that I actually wasn't expecting to see, given that the literature does suggest that individuals who do go and see a dentist might be either afraid or embarrassed to see them. So it was great to actually see that those who did engage in dental service had a great experience. And that included some dentists even going and taking that extra step further to consider things like affordability and how they could work through that. In terms of barriers and challenges to oral health, one of the biggest thing was in the primary care team, so in terms of GPs, dietitians, and psychologists, no one ever actually mentioned oral health to these people. When they did bring up oral health, they found that their health provider often didn't know what to do with that concern that they brought up. Another thing that came out was that they were embarrassed and ashamed that they had done this to themselves. So again, that kind of intrinsic shame and embarrassment, and that kind of discouraged them from going and again engaging in those dental health services. Others were when they were younger and they had an eating disorder. Again, it was that embarrassment to go and engage because sometimes they knew that their parents didn't know that they had an eating disorder. So they didn't want their dentist to kind of disclose that information. And of course, the dentist is quite expensive, came up quite a bit. In terms of a suggested model of care, individuals with an eating disorder really wanted to see resources, and they really wanted to have their health professionals talk about it when they're in the clinical setting. So in terms of conclusions and implications, so oral health issues affect individuals with an eating disorder, and that was one thing that the findings of our study really showed. So this population is experiencing oral health conditions, and it's really important to them. Non-dental health professionals can be used to promote oral health. And a finding that I forgot to mention was that in terms of the non-dental health professionals, they were really happy and accepting to have general practitioners and dietitians come and give them oral health promotion advice. And more resources and training are required to actually support non-dental health professionals in this role. And an example of that is this particular resource up here, which is a collaboration between WSU, ACO, New South Wales Health, and the National Eating Disorder Collaboration, who came together to develop this resource for individuals that have an eating disorder. So yes, that's it. Thank you.
Thank you, Tiffany. Tiffany didn't forgot to add also that she herself is a dietitian, and you know, her PhD is really looking at shaping a model of care where dietitians could play a role in this space. All right, so please join me in congratulating all the speakers. I think they did an excellent job. Could I get everyone present to come down to the front, please? All right, so I'm first going to go to the audience. Does anyone have any questions for any one of them? Yeah, oh, Robbie. Yeah, I was going to go on the thing. So does someone give mic? Give mic.
Question for Abhinay and Rishabh.
Abhinay, are you guys there?
Yes.
You are? Okay, there's a question for you.
Thanks, guys. That was an excellent presentation. That was actually quite interesting. So what is the level of dentistry education or training in? You guys are in final year or?
We are third years.
So what is the education of dentistry, the medical curriculum right now? Is there any, I mean, are you trying to look at showing something to actually influence that? Things like examinations and understanding pathology in the mouth is something which is among all doctors. Is it something you're looking at, or what is the plan around this? Thanks.
So I guess from our personal experience learning about oral health, from what I can recall, and Rishabh can correct me on this, I don't think so. There wasn't very much discussed about like teeth or periodontitis, that type of stuff. Anything that they focused on was either upper respiratory tract infections or neurological diseases. So, well, yes, I think dental and oral health needs to be focused as well on medical school, and that's something we would want to prioritize as well for our focus right now. We're focusing on more so like postgraduate training or GP training.
Yeah, that's right. Just to add to Abhinay, what Abhinay said, oral health conditions are only relevant in med school in the context that they are risk factors for other conditions. Like it comes up that periodontitis is a risk factor for rheumatic diseases like rheumatoid arthritis, but that's all that's covered. So there's no examinations, there's no pathophysiology, there's no anything like that, which is something that has to change, I think.
Thank you. There's a question for you. So once a GP identifies a patient is at risk of CVD due to poor health, in your research currently, is there a guideline for the GP who can advise patients on basic preventative dental care?
So from what we found, there's no real specific instructions as to the level of examination or advice that the GP needs to provide. It's more so up to clinical judgment. And I guess the GP would be referring to dentists ideally, but like we found, there wasn't really any specific mention that this is something that should be done as part of the protocol.
Okay, great. Thank you. There's someone, Lisa, was it Lisa? Sorry, Lisa, you've got your hand up? No. Have I muted them? I sent a text and just ask us. Okay. All right. While we wait, any other questions? Oh yeah, we've got one there.
Those brilliant presentations. There were so many great examples of collaboration across different disciplines. I was just wondering if any of you have advice of how to foster enthusiasm for what has seen as quite siloed work, and how to get dietitians or general practitioners or nurses keen and involved in the now.
when I am talking to other dietitians, it's often the case of once you actually start having that conversation with them and say to them, oral health is actually important. You know, if people can't eat and if they can't chew and if they have sensitivity, that's going to impact their nutritional intake and therefore impact our nutrition interventions that we put in place. All of a sudden, people are like, oh, yeah, that makes a lot of sense. That is actually our business. We should be involved in it. And sometimes it's as simple as something like that. So, yeah, I think for us, it's CPD activities would be the best way to kind of get that information going around and starting that conversation.
I went from nursing, and I think with Jacqueline, I think we both with good friends, but I think the fact that we are both educators, we both work clinically for many years, and now working teaching, lecturing students, nursing students, and I think our own interest in it is awakening them in the interest. We talk about it, having Tiffany was saying, having that conversation with students, and showing them the products, integrating it within the programs of nursing. It is already in the midwifery program that was work started with Ajesh many years ago. So I think that conversation for us now, it becomes an everyday conversation, something that we weren't talking about before. I wasn't even thinking about that too much before I started doing my PhD and getting engaged in this project. For me, it's really important now. Jacqueline?
Yeah, no, I was just to add to what Paula was saying, I was going to suggest even just starting off with a simple in-service for staff. Just it's about communication and education. So I think, for example, from the nursing perspective, if nurses know the impact that their lack of oral health knowledge or oral health activity has or can have on a patient, that motivates the nurse to then learn. So starting off with a simple in-service or something like that, just to get the conversation running, and then having a series of in-services would probably be beneficial from that perspective.
Thank you, Jacqueline. All right, so that one question, we got many people talking, so that's great. I'll have one last question for Namita. And this is not really about your topic per se. You are an international student. You've come here, new country, and you're doing a PhD. Could you share maybe, firstly, why are you doing a PhD, right? And what has been the hardest thing for you integrating into Australia and doing a PhD?
So for me, actually, it was during my undergraduation level where we had this internship program where we come across women with various dental problems. So there was one particular woman who came with which I had to do a basic checkup, and she was in her second trimester, if I'm not sure. So she had severe oral health problems. She had severe bad breath. So I myself was feeling so bad. Why didn't this female brush her teeth? Because it was so bad. So I was feeling so bad, and I shared with my friends. So years later, when I also came across with the same state, I was in my initial months of pregnancy, I was not able to brush my teeth. I was completely in my room. So whenever my husband or my relatives used to ask, why don't you come out? I'm like, I've not brushed my teeth because I'm not able to brush my teeth because of my severe vomiting and nausea symptoms. So that is when I thought, like, I'll do something on. So I initially checked, is there something studies or done to help me in this particular phase? So I literally looked out certain literatures, but there were few that helped me. But still I couldn't find some answers. So that is when I decided I'll do a PhD on this topic. And that's where, so I had I thought, like, I'll do my PhD in Australia. So initially I approached Ajesh for the same thing with the same topic. So I was so surprising that he already have done extensive research in this topic. So he was like, there are like, what are the other topics which you have in your mind? So that is then where I came, like, I thought, okay, I remembered of my grandmother. She always used to tell, I have severe oral health problems. And I'm like, women in various phases just have different oral health problems. And that is where I took up this topic of menopause. And so, to my surprise, that absolutely there is very little information around menopause and oral health worldwide. So that is about my journey towards taking up this topic. So coming to Australia as an international student, it was a bit tough for me leaving my 2-year-old kid and my family. But initially I worked, done multiple jobs, everything. But later I managed to get a fully funded scholarship. And now I've just completed my first year PhD.
Thank you, Namita, for sharing. All right, thank you. Oh, sorry, there was a question from who? Shupi. On the chat. Okay, sorry, Jack, you can stay there. My question, as part of your research, is there any plan to translate your intervention and education training to wider nursing curriculum across Australia?
Thank you for the question. Look, that is a postdoc question. And that would certainly be on my, that would certainly be something that I would be very keen to look at after I finish my PhD, which is heading towards completion. So yes, that's something, that's an area that I would very much like to work on. Yes.
Thank you, Jacqueline. All right, so I think we'll stop there. If you've got any more questions, we can ask later on. So our next session is a CPD workshop that is being coordinated by Dr. Zainab Malik. Zainab? Yes, thank you.
Thank you. Can start. Yeah. Okay. Great. Good morning, everyone. Thank you so much for. I'll just start. Yeah. Thank you so much for your attention to my presentation this morning. My name's Zanab. I'm a specialist in a field of dentistry called special needs dentistry. We have a very mixed audience this morning, so I wasn't really sure what to expect when I prepared this. So my apologies in advance if it is a little bit more clinical heavy, but I think everyone will hopefully take something away from the presentation today, whether it's your first time hearing about the specialty, whether you're a clinician or an oral healthcare professional, taking some tips away from this this presentation this morning. So if you're not sure about anything that I am mentioning, I'm happy for it to be quite interactive. Please do just pop your hand up and we can always take a little break. So the learning outcomes for what we're going to be discussing today, there are quite a few. We'll see how we go with that. But essentially what we're going to touch on are some referral pathways for accessing special needs dentistry services in New South Wales, what the scope of practice is for this specialty, some tips that might help you if you are clinicians in the room in assessing and managing patients with special needs in general dental practice, a little bit more around the consent legislation as well, because that is something that is, I feel, one of the challenges in managing special needs in my day-to-day practice, and some red flags that might help assist you in determining when might be a good case for referral. And if we get some time, we might go through some case examples and give you insights into what I do on a day-to-day basis. So as I mentioned, this will be sort of what we cover during the presentation today. So just to take a step back, I think it's good to first of all introduce what special needs dentistry is. So the Royal Australasian College of Dental Surgeons defines special needs dentistry as a specialty that supports the oral health care needs of people living with a disability, intellectual disability, physical, medical conditions, or psychiatric conditions that might require special needs, special methods or techniques, that to help manage their concerns. So essentially, the way I like to think about it is a modification to the dental treatment plan in order to provide safe and effective dental care. Now, this is actually taken from the New South Wales Health scope of practice for the different specialties, and this is what's listed as special needs dentistry. It's a bit dense, but hopefully you can see the areas that I've highlighted in red. This is what is different, what makes it different to general dental practice. So we are managing the more complex cases. This is not to say that every patient with special needs is falling under specialist scope of practice, but there are nuances in care when a patient might actually be suitable for a general practitioner to manage them, but there might be certain scenarios even within their management that require some advice, mentorship, or comprehensive care by the specialist. So some of the things that I do think are really important to highlight are that special needs dentists are often liaising and communicating with the multidisciplinary team that forms part of a patient's healthcare. They're advocating for the provision of oral health services, and that's something that we do on a daily basis. And today I'd like to think that this is a part of that advocacy, and also managing some of the complex medico-legal requirements around people with special needs as well. So just as a note, and I think it's something that comes up for the clinicians that I work with here at Campbelltown Hospital Dental Centre, we do sort of manage predominantly adolescents who are transitioning to adult services and then beyond that age group, so typically 14 to 16 plus. Our paediatric dentist colleagues will manage children living with special needs just due to the number and volume of patients. We can't take the whole population. So what is the current landscape? It is quite a changing landscape at the moment, and that's why special needs dentistry is becoming a lot more prominent and really valuable. We're seeing people living longer with multiple medical complexities. They're keeping their teeth for longer as well. So we're having to manage that challenge of what's going to happen to them later on in life, and how is their dentition going to be maintained in the context of their general health. We also have increased legal rights and anti-discrimination laws as well as part of our landscape. So we need to be really careful around that, making sure that we are, proceeding in a manner that is fitting with the legislation. And we've also got people that are more aware of what the rights and rights around disability are, especially in the context of the NDIS that's been introduced, and although oral health is not currently sort of part of that, there's a lot more awareness about the services that people can get as part of their packages. And there's an increased demand for services as well. So as you would be aware, there are a number of barriers that do present for people to access dental services, and particularly for those with special needs. We have people that are, often very anxious and fearful, and that might even be in the general population, but where you can't maybe understand exactly what's happening, or it's an extremely unfamiliar environment or a change from your routine. That can even be more overwhelming for somebody. There are often financial considerations, and that's why the public system is really useful to be able to cater for those barriers. We have people that are unable to have a comprehensive examination as well, whether that be general health as well as their oral health examinations, and we'll touch on why that then complicates what I do later on as well. Communication difficulties, so that's where we have to try and find out, other ways to help modify our tailored approach to communicating with our patients, and also a varying degree of education for the carers that are involved in the patients that I do see, and access barriers. So this was just a sort of pie chart, small percentage of people that actually were able to have a full dental examination, just taken out of a clinical audit from a specialist department in a tertiary referral hospital in Sydney. So we're going to touch on a few different facets of special needs dentistry, and because it is quite broad and diverse, we will only be covering sort of the main points. But one of the key sort of perceptions and often misconceptions about special needs dentistry is that it is only about managing people with developmental disability. And whilst that does form a large proportion of the patient cohort that we do see, even within that cohort, it is quite diverse and broad. So often it might be a patient with, some chromosomal abnormality or genetic disorder, even brain injury, acute brain injury or traumatic brain injury patients will fall under the scope, and you can see the wide variety of other conditions that can fall under the developmental disability, and that's taken from our therapeutic guidelines in this space. I think another thing to be mindful of is that genome testing is actually going to change this space quite a lot as well. We have a lot more people who are now exposed to that. So people with intellectual disability who are previously undiagnosed as having an associated syndrome will now have that diagnosis, and that can have implications on oral care and oral health. This is just a small slide to just remember the etiquettes around disability as well, and that is part of, I guess, what we advocate for. We like to have the appropriate terminology and using first-person language as well for our patients. So when a patient walks through the door in my specialist practice, often sometimes even the carers or family or people that are involved in their care are not really sure what's happening in the dental space. They may have impressions that they might, not have had a comprehensive examination for some time, but they may not actually be able to fully appreciate whether that person is having oral pain. So assessment of pain is actually a really predominant part of my practice, and it is quite different to being able to ask a patient, what their pain history is, the severity of their pain, etc. So some of the things that we look at are behavioral changes, and we've taken this from some previous literature. Lotan and others in 2010 actually described some of the different ways that people living with special needs may communicate their pain, and some of the things that we can observe for which you might not be, for the clinicians in the room, might not be something that you actually consider as your first point. So increased grinding of teeth might indicate something like wisdom teeth causing a bit of discomfort towards the back. But I guess we have to be mindful of differentiating from their usual routine or from their usual presentation of some of these habits as well. Dietary changes, sleep disturbance, anything that might be suggesting oral pain. So I was speaking to some of the clinicians a few weeks ago where we work, and they were mentioning, how do I know whether the pain that the carer is describing to me is accurate, and what do I take from that? And one of the key questions that I ask when a patient walks in is who they're coming in with, and often how it's a carer, and how well known to that patient is that carer as well, because that can make a world of difference. Somebody that's known a patient for 8 years is going to have a very good understanding of how they present, and that's valuable information as to how they're describing some change in their baseline. So we're going to move on to some aspects of consent. So as I mentioned before, legislation around consent is really important. It is the key aspect around us not committing battery or assault for our patients. So the key piece of legislation that guides consent in the space where I work is the New South Wales Guardianship Act of 1987, which basically outlines this concept of substitute consent. So this is where a patient may not be able to consent for themselves, and typically that needs to be assessed, but it's where they may not be able to communicate that they consent for a particular treatment, or whether they don't understand the nature or effect of the treatment that's going to be provided. So in the Act, we have a term that's used to basically replace what we often in layman's terms say next of kin, and we call that a person responsible. And the person responsible is the person that will be able to provide substitute consent for any major or minor treatment. And The Act does outline the differences between minor and major treatment, as you can see on this slide. If you're interested, you can go into the legislation and read that as to what the differences are. From a dental perspective, the Act doesn't consider a visual examination, so looking into a patient's mouth visually as a medical treatment. So if a patient is walking through the door, you don't have this consent in place, then a visual examination is fine. Minor treatment might consist of things like fillings, even scale and cleans. I would argue even sometimes radiographs might be a minor treatment for a patient with dysphagia, where a radiograph might cause some sort of aspiration risk. But on the whole, usually it's part of that comprehensive or part of that initial examination for which they may have consent just by virtually walking through the door. But then we go into the category of major treatment. So this is in the space of where a patient might need general anesthesia or any form of simple sedation. That is considered a major treatment according to the Act, as well as where you think treatment might involve the removal of all remaining teeth. So we call that in dentistry a full dental clearance. So that is actually a major treatment, which is something well less known. So there are categories of people who can serve as a person responsible, and there's a hierarchy for those categories as well. So if a patient has had a legally appointed or enduring guardian, then they're at the top of that list. And we always go to that person as providing the substitute consent. That might also be a public guardian appointed by the government, or then we go into the next category. So a spouse or a de facto spouse or same-sex partner. And then we go into a carer as the next category, but the carer cannot be paid for their services. So that's something to be quite mindful of. We don't actually get consent from the carers that are being paid and come through from an agency. And then finally, if there's not any of the other categories available for a person, then it might actually be a relative or close friend. But the key is that they need to have a close and continuing relationship with the patient to be able to make that informed decision for their best interest. So some of the things that I use on a daily basis in terms of practically in assessing capacity, often looking at how independent they are in terms of aspects of daily living or activities of daily living. So there is actually a really useful score, the CAT score of activities of daily living, which assesses how independent a person is in daily activities like bathing, dressing, toileting, feeding, mobility, and continence. And the person is given a score out of 6. So 6 out of 6 means that they're, independent 100% in all of those activities. And then if they are, we can then go to the next step and ask a little bit more around detailed or instrumental activities of daily living, which involves things like managing finances, being able to take a bus independently, making phone calls, having their groceries, etc. So that just, again, gives you a bit more of an idea about how functional they are independently in society, which again guides you a little bit more around, even oral care and their independence with that, and how they might understand what you're proposing as a dental treatment. We are quite lucky. New South Wales also has a capacity toolkit, which is a little bit more broader and generic for all healthcare professionals, but is a useful kit. It's just very long and a bit more comprehensive. And so that's something else to read into if you're interested in really understanding what capacity is. So in terms of what a special needs dentistry consultation might look like, it's very similar to what a general dentistry consultation is, but it's just a lot more detailed and thorough, and really picks up some of the nuances, particularly in the medical history side of things. And so what we're really assessing is the severity and stability of any medical conditions that come up, whether people have had any recent hospitalizations, what their current medications are, but really understanding all those implications on oral health as well. So we'll just touch on some of the red flags in terms of developmental disability, just so I think that was something that a lot of the clinicians that I work with were wanting to understand a little bit more. So I've just put this slide in. And often, there are challenging behaviors that do make a comprehensive examination quite difficult. And that's where we might need to plan for some other way of managing their dental care. So that's often using some other modality of treatment, either oral sedation, relative analgesia or happy gas, IV sedation, or general anesthesia. Diagnostic overshadowing is actually a really important concept to understand, particularly in this group. It's where we might consider their usual behaviors to be suggesting one aspect of their health, and then overlook that it might be suggestive of something else. So, coming back to that example of the grinding of teeth, a patient may be grinding quite heavily as their routine, but that grinding behaviors might just be considered as part of their normal behavior, whereas not really picking up maybe increased frequency or timing of that grinding, and we might overlook that might be their presentation for wisdom teeth discomfort. Dysphagia or difficulty swallowing is actually really common in this group. The therapeutic guidelines for developmental disability reports that nearly 25% of patients with developmental disability have some form of dysphagia, and that has direct implications for oral care and safety of oral care as well, because we can actually be providing care where there's high levels of aerosols, and that can then result in aspiration risk. And we've touched on sort of the complex consents, as well as the multidisciplinary management that a lot of these patients do require. We are quite lucky in Southwestern Sydney Local Health District to have a specialist intellectual disability team available to us, which is a multidisciplinary team involving rehab specialists, as well as clinical nurse consultants, psychologists, and a pediatrician, so they are that multidisciplinary team, and they're regularly liaising with specialists in my field so that we can sort of manage those more complex and difficult patient cases. So we're going to move into another facet of special needs dentistry, which is more geriatric dentistry. So sort of the other side, at the other end of life, when people are getting a little bit older and sometimes moving into different type of residential care. So one of the key pieces of literature around guiding what we know about geriatric dentistry has been the resources by Edinger and Beck, and they proposed this concept called rational dental care, which basically means that we're looking at all the factors of a patient at their stage of life, making sure that we are planning something realistic for them at considering their medical, physical, and mental state. So in this group, and for all groups, I would argue, it's really important that we ask the questions around how we're actually going to carry out treatment, how can we safely carry this out, including being prepared for emergencies, and that is a risk that is very realistic for the medically complex cohort that we manage. If there are physical issues, are we going to need the help of a hoist? Are we going to see the patient in their wheelchair? Or are we going to get them to weight bear into the dental chair? And medical optimization is something that is really challenging for what I do. But if we are planning for things like general anesthesia, we need to know that the patient's going to be able to withstand what we're planning and is safe to carry that procedure out. But it can be quite challenging for a patient who's never had a blood test before, or your dental intervention is the first time that that's ever going to be done, and quite difficult for our anaesthetic colleagues to be able to manage that situation as well. So when we look at the elderly population, we can actually classify them into three broad functional groups from a dental health perspective. So they can either be functionally independent. So these are the elderly that are living in community, and they're quite independent and able to access their own care without any major supports. We've got frail older adults, and so these are the people who might be on a My Aged Care package receiving some supports, but they are living in the community. And then we have the functionally dependent older adults, and so these are the ones that we often see in residential aged care facilities. And we can see that the majority now with our our aging population are living in the community. And so that's a really good reflection of why we're going to be increasingly seeing this cohort in our clinic. Apologies for the slight graphic images, but these are realistic images of what we see in residential aged care facilities. And unfortunately, it is a big problem. Often we are managing, patients who are quite advanced with advanced dementia. Oral care may not be possible or just neglected because there isn't actually appropriate services available. Now, this is changing this landscape, and there are a lot of really great research projects coming out, including the Senior Smiles project, which was designed by Janet Wallace and really focuses on having an oral health care professional or an oral health therapist in residential aged care facilities to support the residents there on a daily basis, and has shown some excellent statistics to be very successful. So psychiatric disorders are another facet of what is involved in special needs dentistry, and there's a big range of conditions that might be incorporated. I've just listed a few, but I think for the clinicians in the room, some of the things that I like to think of as being necessary to possibly seek out some support or mentorship or consider referral might be patients that are presenting with unstable mental health, and that is a red flag where they might be having an acute psychotic episode, and consent is actually going to be an issue at that point. A lot of them will be under the Mental Health Act of 2007, so we can't actually just go ahead and treat without getting some support from their psychiatrist, or a lot of them might be even on a community treatment order, so that's where they're living in the community and need to comply with a particular schedule, and often less considered in our history taking as to whether that's something that is the case or not for our patients with mental health. And as you can see in the red, some of the things that that are important to consider in treatment planning, particularly in the newly diagnosed space as well, because that might actually be a presentation of instability. Now, sometimes that mental health might just be dental specific in the space of anxiety and dental phobia. And this is another cohort that is managed. The reason by special needs dentists, the reason being that there is a severity or a scale that you can think of, particularly if we look to the right of this screen, we can see this really great matrix that was developed by De Jong and others in 2005, where we've got categories of people presenting, where they might have extreme significant treatment needs and really severe dental anxiety or phobia. And for that category of patients, we're really only going to be able to manage them with intravenous sedation or general anesthesia. And so that's when they typically get referred to myself. But even in this category here, where they have severe dental anxiety or phobia and less treatment needs, desensitization, and working closely with the psychiatrists or psychologists that are involved is something that we do as well. I think palliative care was mentioned before as a less considered aspect regarding the importance of oral care, and it's great to see more research being done in this space. From a special needs dentistry perspective, this is also something that we manage, particularly as we do get referrals from palliative care inpatients as well. Managing these acute needs at the end of life is really, really important, and it is about maintaining their quality of life at the end of the day. Physical disability, another aspect of or cohort of patients that comes under the scope of special needs dentistry, and some of the more common, there's a very long and exhaustive list, but patients with cerebral palsy, often presenting in motorized or manual wheelchairs, post-spinal cord injury, motor vehicle accidents, or traumatic brain injury, or post-stroke patients as well. So essentially what we're talking about at the end of the day is medical complexity, and that again, covers every system in the body. Again, a big list of conditions that we see as general dental clinicians as well. But it's really when those medical conditions become unstable and start to build or have multiple medical comorbidities that are contributing to the oral care or to their deteriorating oral health, that may result in a referral to for specialist support. Some of the key ones might be end-stage disease as well, where the patients are in a more palliative setting, and that's something that is ascertained in the history taking, and complex treatment planning considerations as well, when we take into account that prognosis at the end of life. Now, bariatric dentistry is also another facet of special needs dentistry. Whilst not every patient living with obesity will require specialist management, but there is a cohort of people who exceed the safe dental working limits of our dental chairs, which are quite variable at the moment. Manufacturers are making dental chairs ranging from 120 kilograms up to 227 kilograms for our general dental chairs, but there may be cohorts of our community that exceed that weight limit, and we have bariatric dental chairs for that purpose. And this is a area of personal interest, and I'll be later presenting some research in this space, but this is another aspect of special needs dentistry to bring to your attention. And there was a scoping review done in 2016, particularly in this space, looking at some of those clinical and service delivery implications of bariatric dentistry, as well as the patient's experience too. So I think one of the take-home messages for me in hopefully giving you a bit more insights into special needs dentistry is that we really do need to come prepared. A lot of these patients will require some additional modifications to their plan, and therefore the best way that we can be successful in their management is making sure we have as much information prior to them even coming through the clinic. So I regularly use telehealth to be able to ascertain a lot of this information before I even see patients. This is really useful for those with challenging behaviors, where we can really make their in-house consultation as quick and efficient as possible, so we aren't actually going through all the information and then possibly losing compliance just even in that discussion. So these are just some of the key pieces of information that we do request before the patient comes in. I sort of mentioned before the different treatment modalities that are used as part of our specialist services, and we're really lucky that here at Campbelltown we've got access to most of these modalities of treatment. So under general anesthesia, it's not just simply seeing patients while they're asleep and doing their dentistry as normal. There is a lot of planning that goes into it as well, and we really try and take advantage of that intervention to value add to it too. So if patients are requiring additional supports, sometimes we will value add with blood tests, gynecological examinations, eye examinations, just even personal care that can be done. We've had patients where we've coordinated chest x-rays, we've done a lot of other things to really make sure that that intervention is as useful as it can be. And carers, specialists, the whole multidisciplinary team really do appreciate that extra effort. As we were talking before about anesthetic risk, that is something that we don't take lightly. We are really making sure that there is an indication to proceed with dental treatment under general anesthetic, and we try and optimize that as much as possible. So if we know that a patient has quite severe obstructive sleep apnea, for instance, and already managed on a CPAP machine, then we will get them to bring that in for post-operative care. But as you can appreciate, a lot of patients may have presumed obstructive sleep apnea, but might not be compliant with, for instance, a sleep study or a hospital-based sleep study. So we have to take that presumed risk as on face value and make the appropriate modifications as well. And even before we were talking about obesity, that can be quite an important implication as well in flagging that with theatres to make sure that they have the appropriate resources and beds that we can manage patients who have those needs. I think we've sort of touched on that aspect. So we might move into just some case scenarios just quickly to highlight what a patient, a typical patient might present to actually my general dentist colleagues in the clinic, and sort of what I might focus on in their history. So let's look at this 18-year-old female patient with cerebral palsy who presents with hemiplegia and comes in with a wheelchair and has some slight hearing impairment. They also have a history of seizures. They're on a medication to control that epilepsy, and they have normal intellectual capacity. And they're quite high functioning. They go to university, they're living independently, and they've also coped well with dental treatment in the past. So you might be thinking, well, is this really a patient that I need to refer? And I would say no, it actually is a patient case that you could definitely manage for the oral healthcare professionals in the audience, sorry, that you could manage on your own, for sure. And I think the parts that we want to make sure that we hone into and we really tailor their dental care are things around, maybe ascertaining what kind of wheelchair that they present in. Is it an electric or manual wheelchair? If it's an electric one that can recline, we're not going to put this patient at falls risk by hoisting them into the dental chair. We will actually manage them in their wheelchair and keep them as comfortable in their environment as much as possible. We want to try and make sure that we're communicating in a way that they can understand. It might surprise some of you to know that only 50% of people living with cerebral palsy have intellectual disability. So there's a whole cohort of 50% that unfortunately are often considered that they may have some intellectual decline or cognitive decline, but as we can see in this patient example, that's not the case. And so we need to find out a way to communicate in a way that they can understand, and that might be use of a communication board, also managing the hearing impairment, so speaking in a really slow, clear manner, and in an environment where we can reduce background noise as well. So these are some of the things that we've been talking about with our speech pathology colleagues who are currently doing a project on communication. So that's, a really great example of where we can make those differences to provide comprehensive dental management. So we also have an idea about previous history in their compliance for dental treatment. And so that already gives us an indication that, orthodontic treatment or braces is not an easy intervention to provide. It's also a very long-term intervention too. So reading this case scenario already tells me that this is a patient that we might be able to provide excellent treatment for. But the issue about having some dental cavities or dental caries on the hemiplegic side tells me that we can really focus in on the oral hygiene component of things and really use our oral health therapist colleagues to help with that. So I might just move to the next scenario. In contrast, if we look at a patient coming in from residential aged care facility, an 85-year-old male, for instance, with advanced dementia, who has come in, as an emergency type of patient because there's severe weight loss and they're not eating like before. This is a patient where, we might actually need to get our special needs dentistry colleagues involved because we might not be able to ascertain exactly whether it's a odontogenic or a dental related concern that's contributing to the weight loss, or it could be something else as well. And often it's quite hard and unfortunate to see at this end of life where we then have all the historical dental disease or the historical dental treatment failing at a point where oral health is then neglected, and we have to sort of manage this really difficult and sometimes very impossible situation of, a full mouth of dental caries and very challenging behaviors to not even be able to have a look. And so that's something where I then would come in and look at whether we can actually provide treatment in the chair, possibly using some level of sedation. At this patient's age, they're likely to be quite clinically frail, and general anesthesia is not going to be our appropriate modality of treatment. So sometimes we even need to look at palliative dental care in these scenarios, which is quite sad, but really requires good liaison with our GP colleagues as well to make sure that they're aware of what kind of approach we're going to take. So my work is very much involving the whole dental team. And as I was mentioning before, we have very close liaison with our oral health therapists as well. Very lucky to be working with a great team, but some of the aids that I use even on a day-to-day basis to make sure that I can provide the most effective care, or even have a look, for instance, some of these aids that I've listed, and be surprised as how much even just a handheld massager or vibration can help relax a patient with advanced dementia. Similarly, we use these foam mouth props as well to be able to provide effective oral care, and educating carers to be able to open the mouth up at the back so that they can brush the back teeth. So just as my take-home message, I guess what I'd like to make sure everyone leaves today with is that special needs dentistry is not just disability, and it is quite a broad specialty as well. We do encounter a very wide range of patients, and I guess it's not every patient that presents with this medical condition or medical complexity or type of need that is part of scope of practice, but those that are really complex, requiring perhaps some nuance of care that might need some specialist support. And just to give you a little bit of context, sorry, I should have mentioned this at the beginning, we really only have 27 special needs dentists in all of Australia, and only 7 working in New South Wales. So yeah, that would have been a good to add at the beginning, sorry, but helps provide a context as to why we can't actually look after every single patient presenting with these needs. So we are here for supporting our oral health care professionals in the more complex cases. And what we're aiming to do is really providing people with a dental home, and the American Academy of Pediatric Dentistry really well defines this concept of dental home as well as being a comprehensive, continuously accessible, coordinated and family-centered approach to care. And that's what we're all about, because the evidence does show that a dental home is really necessary, particularly when our patients are presenting with needs that require continuity, familiarity, and a really empathetic approach. So that was just a small taste of special needs dentistry. I do hope you enjoyed it. These are some of the references I've used. Thank you so much for your attention. Very happy to answer any questions, and my apologies for those that maybe that was a bit too clinically heavy. Sorry. Oh, okay, please. No, great.
So I'm glad you were saying that you're actually working well in the interdisciplinary team.
Yes.
But do you think there are still challenges from that side in terms of working?
That's a great question. There are definitely challenges that we experience. I think partly because I guess from my own personal experience, special needs dentistry is a less known specialty even amongst dentistry colleagues, let alone our medical colleagues as well. And when you're working in a tertiary hospital, often, you know, you're reaching out to medicos and it's the first time that they've heard of the specialty. They might not understand exactly what you're there to provide and what your scope of practice is. So there are barriers just in terms of lack of awareness, but I would say that also multidisciplinary approach is really well accepted, and often when it's brought into the care of the patients, our medical colleagues and allied healthcare professionals really appreciate the value that it does bring, because at the end of the day, it's really about improving patient care and outcomes. So yes, for sure, barriers, but some of them more systemic and some that can be definitely overcome.
We've got 2 people raise their hands.
Oh, okay,
Just
sure.
feel free to unmute yourself and ask your question.
All right. Let me just. So Wasan, you've got a question.
Yeah, thank you very much. Actually, it's first of all, I have to thank Dr. Zainab Malik for her fantastic presentation. And I had the opportunity to work with her by referring some patients and she's really very caring specialist and very useful. Thank you very much. I just wanted to mention one thing. As she mentioned, because of the limited number of special care dentistry, there are a lot of things we can do as general dentists, and I think that would help our patient. And all what I can ask Dr. Zainab, if she can empower this about we don't need to be scared once we see patients who have certain kind of special need to straight away we would think about referring them. There are a lot of cases when we can treat, and also the other thing, sometimes by checking some x-rays, the thing is not only if there is no pathology, nothing, if the patient has no symptoms and can function well, then we don't need to go and pull more teeth and create more problem to the patient. And then we need dentures and all the sequences. So my question to Dr. Zainab, if she can empower that about, we are aiming all for painless, functional, not ideal things when patient can eat without pain and can practice daily routine normal. Am I right, Dr. Zainab?
Very right, Hassan. Thank you so much for bringing that important concept to the table. Very true. I mean, with the limited number of specialists available, we do need to rely on our general dentist colleagues and our other oral healthcare professionals to really step up to the table. And for sure, that doesn't mean referral at the first sight of a patient with disability coming through the door. But I think it is, there has been research actually done in this area that there is some hesitation amongst general dentistry colleagues, and I think part of that is because it's less comprehensively addressed in the curriculum. You can see from just today's presentation how diverse and broad the scope of special needs dentistry is. It's not possible for a 12 series lecture series for an undergraduate dentistry student to go through that in the amount of detail that they need to be able to feel confident. But the support with a specialist, the mentorship that can be obtained from senior dentists who are more skilled in the area is a really good step forward. And I think public dentistry is excellent in that regard, in that you have that mentorship and that tiered approach to providing care. So very I agree 100% with what you're saying. The often emphasis for what I do is really about preserving function, making sure that we have functional capacity and painless approach as well. Because unfortunately, sometimes even some of the typical treatment options that we have are not always applicable in this cohort, where dentures might not be tolerated, or implants, or other more invasive dental treatment options may not be suitable. So we really need to try and preserve the dentition as much as possible, and that's why prevention is actually the most important part of my work.
Yeah, thank you very much. Thanks.
Thank you. We might just take the last question. So is it, sorry, I can't pronounce it, Nomer?
Yeah, it's Naomi. How are you? Look, great presentation. Thank you very much. This question I just want to ask, I know that we're going to go further into it as we go through the research showcase, but you mentioned, Doctor, something about palliative dental care. What does that look like?
So palliative dental care is a approach where we are focusing on the same principles of palliative care in general, preserving quality of life. So it's not always that the patient is at the end of their life, but it might be that, we've assessed prognosis is, maybe less, or, only maybe 3 to 6 months, and we don't need to go in and remove every decayed tooth or infected tooth if the patient is living well, comfortable, eating well, sleeping well, and there's no signs of oral pain. So it's taking an approach in conjunction with the person responsible, with our substitute decision makers, that is in the best interest of the patient. That approach is often done in conjunction with our specialist medical colleagues as well, who might say to us that it's actually not safe enough to carry out an invasive dental treatment option like extraction of a tooth in a patient who's got a hematological malignancy and their platelets are too low that, taking a tooth out without proper coordination might put them at risk of a severe bleed and life-threatening bleed. So, in that scenario, we're going to take a palliative dental approach to the management of that particular tooth. But it is quite a nuanced concept, and sometimes it is in patients who have palliative and supportive care needs. It can vary in terms of its meaning case by case. I hope that helps a little bit.
Thank you. So I think just join me again in congratulating Senap on a wonderful and informative presentation. We're actually running a bit over, but we're going to break for morning tea. So can I get you all back at 11 o'clock sharp, please? And morning tea's outside there. And guys online, yeah, please come back then. Thank you. Thanks for coming back. We're going to start our session 2. Which is targeting priority populations. So our first presenter is Tiffany again. So Tiffany is a PhD student, but she's also works as a research officer, and she was part of this project with the lead, Professor Nathan Wilson. It's actually a nice segue to Zainab's presentation from the other side. So.
Good morning, everyone. So individuals with an intellectual disability are known to experience poor oral health, and generally that can lead to a decline in their quality of life. In addition to that, they tend to also experience some limited access to oral health services. In terms of that and access to their dental services, sometimes it can also be difficult in trying to access their specialist dental care services as well. And in considering like the logistical requirements to actually get them to accessing the service, and then the experiences that they might have once interacting with the service. So disability support staff and family members can actually provide a kind of bridge between them and their oral health and their oral hygiene, and supporting them to actually manage their oral hygiene as well. However, at the moment, we know that there is limited literature that currently exists exploring the requirements of those that take on a disability support worker role in looking after individuals that have an intellectual developmental disability, looking after their oral health. In terms of the current literature that does exist, as I said, there is not a lot that's actually out there, but those that have looked at it look at traditional didactic and practical teaching models. However, in a survey of a training program that was done in Australia, what they did find though was that post-training, the disability support worker knowledge decreased after the actual training, which suggests that we need to look further into the training models that are actually provided to the disability support workers and see how they can be further supported in this particular area. So that brings me to the aims, and the aims of this study was to describe the disability support staff knowledge about their oral health and to explore their practices and perceptions about supporting those with an intellectual or developmental disability around their actual oral health. And we did this by using a cross-sectional survey. So recruitment was looking at anybody that qualified as a disability support worker in Australia, and we used purposive sampling. So we used a publicly available database that was through the NDIS and looked up all the caring facilities and sent out an email with a survey link. And the survey was made using Qualtrics and sent it out to all the disability support worker services. In terms of analysis, inferential and descriptive statistic analysis was conducted. So just looking at the demographics of our participants. So we had 156% of individuals complete approximately 50% of the survey, and they were used in the analysis. So 58% of the individuals who participated were female, 79% had a university degree or diploma, and 80% were working in full-time or part-time employment. Participants were largely from New South Wales, Victoria, and Tasmania. And 69% of them were working in a group home versus 25% that were working in home-based living. So the survey itself had 5 key areas, and I looked at the knowledges, practices, barriers, training, and the demographics section. So we'll start with knowledge. So more than 50% responded correctly for items linked to risk for oral health and preventative measures. So what we found was a lot of the participants actually knew quite a lot in terms of risk to oral hygiene and preventative hygiene measures that could be taken. However, the link between oral health and other chronic diseases, that's where their knowledge kind of dipped. In terms of perception, so 96% felt that oral health is important to them. 58.3 felt knowledgeable to care for oral hygiene, and 38.3 felt that they were equipped to promote oral health. 73% of participants felt confident in assisting their client with their oral health. But in terms of barriers, although 54% felt that they had enough skills to perform oral health and hygiene with their client, 60% felt that training was inadequate. And this was more associated with those that had higher educational qualifications. In terms of training, a quarter of the participants had actually received training, but 88 of them felt that following training that their practices had changed. So what does this mean? I guess in terms of prioritizing oral health, that can be quite difficult for disability support staff. And they acknowledge that often that they have competing interests when trying to manage that. And sometimes there can be aspects where the client that they're working with may be experiencing fear or anxiety in terms of managing their oral health. But in saying that, they all had a very positive attitude towards participating and engaging their client in their oral health, and also felt that they could make it a priority. In terms of when you compare that to the literature, as I said, current literature that exists said that those that were receiving training had a bit of a knowledge change, but the participants in our study felt that if they had training, they would improve their knowledge. So there is some kind of engagement that we can tap into in terms of helping improve their knowledge and going on to develop a kind of model of care that targets this. But we need to consider training that is holistic and tailored to the actual skill of the disability support workers. So further research is still required to actually inform that model of care and the training that can be provided. That's all.
Thank you, Tiffany. All right, our next presenter is Alicia Johnson, who's a clinical nurse consultant in our district, and she's going to be talking about her PhD topic. Welcome, Alicia.
Imagine you are 15 or 16 years old and you experience hearing voices. You're admitted to an adolescent inpatient mental health unit where you're commenced on antipsychotic medication. After a few weeks, you are discharged, and over the next year or two, you're followed up by a community mental health team. Fast forward 5 or so years and you stop taking your medication, because why not? You're feeling better and haven't heard any voices recently. After a couple months, you're admitted to an adult mental health unit with a relapse of psychotic symptoms, where you find yourself asking the nurse for paracetamol for that nagging toothache, or asking for mashed potato for dinner because that's all you can possibly chew. Unfortunately, these are the stories of 2 mental health consumers that I cared for in an inpatient adult mental health unit, and unfortunately, it is not an unfamiliar one. As introduced earlier, my name is Alicia Johnson and I'm a clinical nurse consultant within the Southwest Sydney LHD Mental Health Service. I'm also a PhD candidate at Western Sydney University, and today I'm going to be speaking about our systematic review. It is well documented in the literature that individuals with a mental illness experience significant oral health inequalities compared to individuals without a mental illness. Psychotropic medication used in the treatment of mental illness can cause hypersalivation, resulting in dry mouth, leading to dental caries. Furthermore, symptoms of mental illness, such as anhedonia and amotivation, can result in reduced self-care, which can lead to decreased brushing. This systematic review is part of a larger PhD study looking at the oral health of adolescents with a mental illness and potential nurse-led strategies. The aim of this systematic review was to synthesize evidence regarding oral health knowledge, attitudes, and practices of people with a mental illness. So initially, the protocol for this systematic review was registered in Prospero. 6 databases were searched, yielding a total of 1,370 results. The Covenants program was used to assist in the screening process, with a total of 35 studies included in this review. Our exclusion criteria included a primary diagnosis of drug and alcohol, as well as eating disorders, due to the additional oral health complexities that people within these populations face. Quality of studies were assessed using the JBI checklist that aligned with the methodology of the corresponding study. Our first major theme was oral health knowledge, which included the 2 sub-themes: preventative oral health practices and side effects of psychotropic medication. Most studies reported low or basic levels of oral health knowledge, irrespective of diagnosis, gender, or age. Most studies Participants had limited understanding regarding preventative dental visits and importance of regular brushing and flossing, with some participants reporting that they only learned of this after experiencing a significant decay. Our second major theme was oral health attitudes, which encompassed the sub-themes: impact of mental illness, oral health not a priority, cost as a barrier, poor communication, and dental fears and practical barriers. Some participants reported that symptoms prevented them from attending to dental visits or brushing their teeth. Cost was identified as a barrier in studies which included limited income, lack of insurance, and due to their financial current situation, affected their ability to attend the dentist. Additionally, some participants identified that they would opt for a less expensive option, such as a tooth extraction, rather than a series of dental procedures due to cost. The third major theme was oral health practices. This included toothbrushing aids, in which ownership rates ranged from 38.3%, with higher rates of ownership having formal support services in place. Frequency of brushing ranged from 2.7% to 72% for daily brushing. All studies that looked at daily brushing reported no more than 40% of participants were twice daily brushing, and in 3 studies reported 10% or less participants brush their teeth twice a day. This review highlights some of the challenges faced by people living with a mental illness that affect their oral health knowledge, attitudes, and practices. This review suggests that although people living with a mental illness experience barriers and challenges, healthcare providers and carers could be involved in facilitating oral health practices through working in partnerships with carers and with people with a mental illness. It has also highlighted the need for oral health promotion. In studies that had high oral health practices, such as frequency of brushing, these participants were also linked in with formal support services or participated in outpatient health promotion services. This gives rise to the opportunity of providing basic oral health education to consumers. Additionally, mental health care providers may utilize contact with carers to provide education regarding the importance of oral health, including brushing their teeth, and dental visits. Thank you.
Thank you, Alicia. Our next presentation is around alcohol and other drugs, and it's a joint presentation with Kaniz from Drug Health Services and Shweta from our center. Where's Shweta? Oh, yeah.
Okay. Thank you, Ajish. Good morning, everyone. Me, Kaniz Fatima, Research Coordinator, Drug Health Services, along with Ms. Shweta, Research Officer at ACIOH, Western Sydney University. And jointly today, we are going to present perception of clinicians on promoting oral health care in alcohol and other drug use healthcare services. So all of you know, next slide, please. Okay, next slide. The use of alcohol and other drugs can increase risk of tooth decay and gum diseases. Individuals with substance use disorders often have compromised immune system and a greater inclination towards consumption of sugary foods and beverages. These worsen their oral health problem and result in decline in oral health related quality of life. So dentists often face challenges when treating individuals with substance use disorder. They may overprescribe opioid medications, which are addictive and highly prone to abuse. Valuable opportunity for AOD clinicians to initiate a brief intervention and promote oral health. So we aim to explore current knowledge, attitude, and practice of AOD clinicians in Australia regarding oral health care among their clients. So we used our next slide. We used our exploratory quality design, which involved a semi-structured interview with AOD health professionals working with drug health services. We interviewed in total 16 participants, 7 GPs and 9 nurses. The interview time were about 15 to 20 minutes, audio recorded, transcribed, and then we thematically analyzed. Now Shweta will present the results.
The themes that emerge from the data include perception of oral health among AOD clinicians, barriers to incorporating it into practice, and recommendations for integrated care. In short, all participants reported high prevalence of dental problems among their clients and had a good understanding of the importance of oral health. Participants raised that oral health had a big impact on the clients' self-esteem and on the belief of being accepted in the community. It was suggested that oral health education should be provided by all health professionals who see clients in AOD settings. However, most participants reported not discussing oral health with their clients unless being prompted by the client about an oral health related issue. This was due to various barriers, including time constraints, oral health being a low priority for the client, and lack of accessible and affordable dental care. Both GPs and nurses emphasize the need for integration of oral health screening into general assessments and for a prioritized referral pathway to dental services. They also added that having resources such as brochures, patient education videos, and protocols or guidelines for dental referrals might be useful. In conclusion, our findings suggest that oral health care and management is often not prioritized in AOD services due to various barriers. Developing and implementing a tailored oral health model of care would be required to evaluate the needs of the clients, improve referral pathways, and empower AOD clinicians' training and resources to promote oral health. Thank you.
Thank you, Keniz and Shweta. We'll get questions to you at the end. Oh, great. Our next presentation is by Agnivo Sengupta from our center, and he's looking at palliative care. I'll take your time.
Thanks, Ajesh. Hi, everyone. My name is Agnivo. I work as a research officer in ACO. Today, I will be presenting about a study where we explored the perceptions of dentists regarding the provision of oral health care to individuals receiving palliative care. As we all know, Australia has a rapidly aging population due to increasing life expectancy, which means that there is an increased need for a quality palliative care. However, oral health is often neglected, as has been highlighted before in this showcase, and this causes further health-related complications such as dry mouth, changes in taste and speech, increased sensitivity, increased frequency of painful oral infections, which ultimately contributes to poor quality of life in these patients. So the NSW government has set out the vision for palliative care, but the importance of oral health has been neglected and overlooked. So what we aim to do in the study is we explored the perceptions of dentists towards providing oral health care to patients receiving palliative care. What we did to achieve this is we conducted a qualitative study by conducting a focus group discussion with 21 dental officers from a single health service in the Greater Sydney area. The discussion was audio recorded, transcribed, and thematically analyzed. So here's what we found. Dental officers in our study reported seeing a high prevalence of poor oral health among individuals receiving palliative care, and they were also well aware of the importance of oral health care in this population. Certain challenges were identified as well to providing oral health, which included competing priorities for patients who are ill, which meant that oral health would easily go down the priority list for individuals who were critically ill. Dentists also reported experiencing challenges relating to the coordination of care between the dental service and other health services, and experiences such as difficulties in contacting patient specialists and not being well informed about the health conditions of the patients were also mentioned. They also recognize their lack of experience in working with the individuals receiving palliative care. They also discussed how the lack of formal training affected their confidence in treating this patient population. Next up is a new model of care also emerged from some of the strategies which could be implemented to meet the practitioner's needs and the patient's needs. The need for formal protocols to ensure quality care and maximizing treatment and care with reduced number of dental visits for patients. My colleague Vipin is taking this work to the next level, where he's looking to develop this new model of care as a part of his PhD. Finally, we came to the conclusion that dentists do face challenges in providing oral health care to individuals receiving palliative care, which calls for greater collaboration between oral health and palliative care services to devise a new model of care that caters both to patient and dentist needs. Thank you.
Thank you, Agniva. The last presentation for this session is again from Dr. Zainab Malik, and he's going to look at obesity. Thank you.
Hi, everyone. Hopefully you're not sick of me yet, but good morning. So for those who might have just joined, my name's Zanab. So as you all know, I'm a specialist in special needs dentistry and also a PhD candidate. Today I'll be presenting the findings of a quantitative study that formed part of my PhD studies evaluating weight stigma in the dental setting. So unfortunately, it's well documented that people living with obesity commonly experience weight bias, stigma, and discrimination. But what is weight stigma? Weight stigma has been defined as the discriminatory acts and ideologies targeted towards individuals because of their weight and/or body size. This includes negative stereotypes and attitudes, as well as the resulting negative behaviors and treatment of individuals who are affected by overweight or obesity. Although this is unethical, weight stigma has increased by 60% compared with discrimination towards other social groups and remains one of the few socially acceptable forms of discrimination. Weight stigma at its core revolves around the belief that obesity is completely under the individual's control. As we can see on the diagram on the right, the figure represents the interactions between the environment and the individual and the numerous drivers, whether it's genetic, psychological, economic, societal, or the changed biology of those living with obesity. There is evidence indicating limited training amongst dental professionals regarding obesity or obesity-related stigma. These studies have predominantly focused on student cohorts and have been carried out internationally in the US, Pakistan, and Saudi Arabia. However, studies have minimally explored the Australian context and have not included support staff. So we embarked on a cross-sectional survey, which aimed to assess the stigmatizing attitudes and beliefs of dental professionals. So that included registered general dentists in private and public practice, oral health therapists, and support staff, including dental assistants and dental receptionists, working both in private and public regional practices in New South Wales, and the perspective of special needs dentists across Australia towards people living with obesity. We also wanted to assess the exposure to obesity-related education. So we used an anonymous electronic validated survey previously used in the dental setting by Maglioka and others in 2005. The phrasing of the survey questions used for our study was adapted based on theirs, but adapted to reflect adult obesity and person-first language. We then administered this survey through RedCap survey platform to assess stigmatizing attitudes and beliefs held amongst respondents in relation to people living with obesity. So we had 53 participants complete the survey. This included 33 clinicians and 20 support staff. The majority, so 88.7%, held positive attitudes towards people living with obesity. Only 3 clinicians reported negative reactions towards the appearance of someone living with obesity or discomfort during an examination of a person with obesity or perception that they were lazy compared with normal weight individuals. In comparison, 20% of support staff reported responses indicating negative attitudes, particularly regarding perceptions of laziness and lack of willpower and motivation for people living with obesity compared with those of normal weight. Of the clinicians, 45.5% reported 1 hour or less, and 42.4% reported 2 to 5 hours of obesity-related education. 24.2%, so 8 clinicians, reported no undergraduate training on obesity during their oral health training. Of the specialists in special needs dentistry, 45% reported that their knowledge of obesity was acquired predominantly during their postgraduate training for their specialist qualification. In contrast, we had 70% of support staff reporting no prior education or training about obesity. There were mixed responses for interest in learning more about obesity. A higher proportion of clinicians, so about 94% compared with support staff, or 60% of support staff were interested in learning more about obesity. So in conclusion, the survey responses reflected evidence of weight stigma in the dental setting and reflect a need for professional development targeting weight stigma reduction in the dental setting for both dental professionals and support staff. Just like to acknowledge my supervisors who have supported me in the project, and these are a list of the references that I've used. Thank you.
Thank you, Zainab. All right, can I call on the presenter to come to the front, please? All right. So firstly, any questions from the audience for anyone? Anyone online? Any questions? All right, while you guys still think, shouldn't rely on me to ask all the questions, guys, come on. All right, Tiffany, do you know, I know you're not leading the project, but do you know what are potential plans moving forward with this project in terms of the carers?
No. I don't think I really do. No, I think from last recall, and just thinking about what Professor Nathan Wilson, who actually leads this area of study, is thinking of doing, was actually looking forward to developing a training program to assist disability support workers. So I think a bit more research needs to be done around that particular area in terms of wanting to know exactly the areas that they want to look into in particular. But yeah, I think it's definitely looking towards developing that model of care to support them.
Great, thank you. My next question is actually for both, I guess, Ignivo and Zainab. Both of you have highlighted the limited training, right? That was a common thing. I guess, do you feel more needs to be done in the undergraduate level to start addressing that? And I don't know if Heiko is here. Is he here? No. Don't. Okay. I don't know if Bradley wanted to, but I guess how the other thing is, well, is it, do you think so? And two, how would you actually go about doing that? What do you think needs to be done? And if there's anything that's been done in the literature to support that?
Thanks, Ajish. I think there's definitely at the undergraduate level, there needs to be changes in the curriculum to integrate oral health education, because I can only speak from the study point of view. And yeah, there was dental officers mentioning that they didn't have any experience or training, formal training, and that they would really love to do that, or probably have a oral health day or day at the clinic or something like that. Zainab wants to.
Just add to that. So for my,
You want to keep it a bit closer? Yeah.
Better?
Yeah.
For my topic specifically, there's been historical data. Actually, we've had data from like 1995 show that very little training on obesity is carried out at the undergraduate level, and now 20 years plus onwards, it's pretty much the same. So I think there's a lack of translation of findings into clinical practice and into the curricula, which does require investment from our universities and other institutions. But I think it's not just the undergraduate level, particularly with obesity training, because there's a whole host of clinicians postgraduate that are currently facing these implications in clinical practice, and there needs to be some continuing professional development as well targeted towards them.
Great, thank you. And oh, okay, so many questions now. All right, Paula. Yeah, yeah.
Yeah, sure. So from my clinical experience, we see a lot of people come in with oral health problems into the mental health setting. Being an acute mental health unit, we usually treat the mental illness acutely at that point, and we tend to see a lot of the other physical health side of things we say can be followed up in the community. I mean, from the findings of the systematic review, we've seen that people with mental illness aren't able to attend the dentist. They've reported cost as being an issue. So I think the access from the inpatient setting, for example, where we're not being able to link them up from there, they are going back into the community, not necessarily with much follow-up from the community team. Sometimes it'll be a 7-day follow-up. So they haven't really got that support there to help them book in a dental appointment or to attend that dental appointment. We often do try to refer people from the community, from the inpatient setting to the local dentist, the public dentist, and there is lots of wait list times. Sometimes they're too acutely unwell for us to be able to take them over there. They don't have leave from the unit. So then they have to go back on that wait list. Trying to get another appointment for them can be difficult at times.
Thank you. Wait, a question? Yep.
Yeah, no, that's a great question. So there are a number of multidisciplinary obesity clinics, so family-based, looking at whole of lifespan obesity across New South Wales. One particularly where I did some previous research was the Nepean Family Metabolic Health Service, which was the first family targeted obesity service in New South Wales, and showed really good evidence that that was successful. And that's an integrated team of dietitians, psychologists, endocrinologists, GPs, and support work and social support workers. So I think having seen that in practice, it really isn't a beneficial service. Of course, what's lacking is oral health. And going to that service and asking people about their oral health and the barriers that they face did form part of some research that I've published. But I think it is a very difficult problem and really requires a lot more funding in that space to improve care for in general, but also integrate oral health into that education and awareness. And, you know, even in that, based on like my findings with the previous studies, barriers were stigma, and that's what actually started my PhD topic. Just with answers, in answer to your question around mental health, it is a real challenge with wait lists, but I think with our priority oral health program in the public clinics, we do have prioritization for people with complex medical conditions. So that does include psychiatric needs or mental health that is uncontrolled. So there are attempts, but for sure our services aren't 100% meeting the needs that are there. I think something to look at would be integrating possibly ward-based visits. So actually bringing the dental team into the hospital and into the mental health units. But that requires additional training and comfort and money. Yeah.
Thank you, Zainab, for answering two questions there. That's all right. And the last question is actually for Shweta and Kenise. Is Kenise there?
Yes, I'm here.
I guess I wanted to know currently, because obviously you work in drug health, so what are the current strategies, or are there any strategies for oral health promotion among the clients in the service?
Yes, not. We are actually doing some work, but not in a very large scale. So we, in future, as a part of the today's presentation, we are going to do some other works, and then we'll develop the promotional things in general for our clients.
Okay, thank you. Shweta, have you come across anywhere in the literature about models where they have had some success in promoting oral health among drug and alcohol?
Not really. In most of the literature, it highlights the need for having interventions in oral health. There are a lot of literature about the issues in oral health in alcohol and drug uses, but we don't really have a model of care that really looks up to, you know, how do I do the screening out, or to help the clinicians on how to go about doing it. So we do lack resources in this regard, yes.
Yeah, thank you. I know one of my colleagues in North Richmond in Melbourne, they were trying to integrate oral health into the injecting rooms. They're promoting oral health there. Yeah, but they haven't really evaluated. All right, well, thank you so much. Please join me in congratulating everyone again. Thank you. All right, our next session, which is actually the last session, is about improving clinical outcomes. And the first presenter is Dr. Sanchana Mowbray. Welcome.
Thank you, Dr. Ajesh. Hello, hi. Can everyone hear me? Hello, hi. So coming to my presentation, I'm Sanjana, as you all know. I have a pediatric background from overseas, and my topic for today is association of oral candida albicans with severe early childhood caries. It was a pilot study which was conducted overseas. Coming to the background of the study, in early childhood, children are more susceptible to opportunistic microbial colonization in the oral cavity due to their immature immune system because they're so young, and also not fully established microflora. The current literature proposes a probable role of Candida albicans, fungus, in the etiology as well as the pathogenesis of dental caries. Coming to the aim of the study, there are two parts to the aim of the study. One is to identify the association of Candida albicans with severe early childhood caries, and also to assess the Candida albicans count in children in different age groups, that is 12 to 36 months and 37 to 71 months. That means it is before the permanent dentition erupts in the child's mouth, okay? Coming to materials and methods, so what we did was we conducted the study in 40 healthy children, which were randomly selected between the age group of 12 to 71 months. They were subdivided into a severe early childhood caries group, which had the DMFS levels of greater than equal to 4, and caries free, which was a control group with DMFS levels of 0. They were further subdivided into groups between the age groups of 12 to 36 months and 37 to 71 months. The caries experience, that is DMFS index of the 40 children, were recorded using visible light and a diagnostic instruments. A 2 ml sample of unstimulated whole saliva collected from the children was transported to the microbiological laboratory in universal containers in sterile formats and evaluated for Candida albicans count using the selective media of Chromagar. The data was statistically analyzed using SPSS software of 17.0. Coming to the observations and results of the study, these are just numbers, but just to brief you guys through it, the most important value is the p-value. That is the last column that you guys can see. It said that it's 0.012. That means it was highly significant. Candida albicans count in severe early childhood caries was highly significant in the severe early childhood group in comparison to control or the caries-free groups. Coming to the conclusion and implications, a high association was found between Candida albicans and severe early childhood caries in the study. This study suggests that Candida albicans may be responsible for the initiation as well as the progression of severe early childhood caries in the very young population with immature immune system because their microflora is not very developed as well and immature. Mouth rinses are used generally for the analgesic, anti-inflammatory, antimicrobial, and anti-cariogenic activities to decrease the prevalence of dental caries in addition to the usual prophylactic measures like brushing and flossing. In addition to this, antifungal agents should also be used so that the growth of Candida albicans, of fungus, is under control to prevent any dental caries caused due to it. Now, having said that, this because the group is so young, it's really hard to maintain their oral hygiene and to use these agents of anti-inflammatory, antimicrobial, or antifungal agents on them. and to make sure the outcome is really positive. So that's why further studies are required in this area to help in the management and prevention of this chronic early childhood disease. It is important that dental practitioners, that's what the reason I'm here today, is just to create that awareness of this association between Candida albicans and early childhood caries or severe early childhood caries, as it may inform the development of preventative risk strategies to help serve our younger community better. Thank you so much. Thanks for listening.
Thank you, Sanjana. All right, our next presentation is Dr. Rashida Jamie, who's going to be talking about her study around intellectual disability.
So many times we have come across a situation wherein it's a Friday afternoon and we see a patient with a facial swelling. To complicate things, the patient has got intellectual disability. I have come across a similar situation and that drove me towards this research. So this is an unsolved paradigm. So just a bit of a background, intellectual disability affects about 2.5% of the population. And dental caries and periodontal disease affects twice in these patients, and permanent dentition affects more. We know the reasons. It's because of the compromised oral hygiene, compromised dental care, and poor description of pain. So why do flare-ups occurs in patients with intellectual disability? And why do they tend to get referred to the tertiary hospitals? And what is get done in tertiary hospitals? We often assume that it's general anesthesia. And what are the system changes that we can recommend or bring in? And that is my research topic. It's an MPhil research. Data was collected in 2022 at Westmead. Ethics was applied. A consent waiver was requested and a questionnaire was developed. I went through hundreds and hundreds of files, out of which 91 records met the inclusion criteria. And based on the questionnaire, we will discuss the questionnaire as how the results go. But when we look into the results, the majority of the referrals were made by the other health practitioners like GPs, specialists, pediatricians, neurologists, geriatricians. The second majority were from us, the dental officers from the community clinics. I must say I came across some of mine and some of our colleagues as well. The third was from the private dentist, and the fourth were some miscellaneous. Majority of the referrals mentioned about intellectual disability, while some said about physical disability and physical threat to the clinician. The majority of the referrals spoke about a localized abscess and change in behavior. Some of them mentioned about a history of facial swelling as well. While maximum number of the referrals said about behavioral issues and physiological limitations like bedbound, chairbound cannot be seen, and some of them mentioned about non-compliance. When we look into these patients, 40.7% of them were regular attenders as pediatric patients seen in transition clinics and then into the adult clinics. But every time there was progression in severity of ID. So majority of these patients were independent in their everyday activities, including toothbrushing. They live with their families and the family member was the primary caregiver. Astonishingly, many of them had unhealthy snacking, with fizzy drinks and some cokes and cakes. The outcome, we all assume that majority of these patients, these patients were seen in GA, but it's not. Majority of the patients were seen in normal settings. The second majority was under general anesthesia, and the third was in IV. So who provided the treatment? They were the specialists, the registrars, the residents, the dental officers who are employed by the Department of Special Care, or in other words, they are trained by the specialist. So what are the reflections? We all know that there is carer shortages and time restraints in this area of field. My research shows that 42.9% of the carers needed motivation around oral hygiene. To back up my research, Flippo et al. In the research article mentions that 40% of the caregivers were not aware of the interdental cleaning, and only 14% were knowing that toothbrushing is a part of general hygiene. So we all assume that general anesthesia is an easier choice, but every time the patient is taken into general anesthesia, the severity of ID increases. So what can we do about it? What are the recommendations? The health professionals like GPs who are the maximum numbering, who are the actual contributors of these referrals, must be given the actual numbers about the wait list and the backlog so that they can redirect their referrals to the other specialists or the other dentists who are experts in the field. We have to focus on the oral health programs to educate the family members and the primary caregivers. General dentists like us must be given opportunities to expand our expertise and also to observe specialists and to attend some training programs. In other hand, the tertiary hospitals must offer some programs for us to equip in such services. Every time the GA seems to be an easier choice, we have to try and attempt to see these patients under normal settings if it's provided to be safe. And while doing the treatment planning, we have to look into incorporating long-term management plans like concept of shortened arches or application of Seattle pathways and everything. So, yep, these are my supervisors. Without their help, I would have not been able to complete this research. Thank you.
Thank you, Rashida. All right, our next presentation is by Rebecca Kamas, and it's around communication for safe care. Oops, sorry. Oops, I flipped it around. Do you mind if I call it? Eileen, you okay to go now? Sorry. Sorry. Otherwise, I can go back. Oh, good. Okay.
Okay. It's orthodontic outsourcing pilot program, a reason someone smiles today. Background: malocclusion is a great concern affecting children in SWSLHD to varying degrees. Access to orthodontic treatment is a big challenge for the community. A long wait list, which when not tackled at the appropriate time, could lead clinicians missing on a window of opportunity to treat complicated cases through dentofacial orthopedics, eventually requiring more complex treatments as an adult, such as jaw surgery, which could lead to increased costs to the public system. Malocclusion, if not treated, can result to jaw problem, speech problem, low self-esteem, social anxiety, social avoidance, chewing problem, increased risk of gum disease, and increased risk of carious lesion. The aim of this project is to develop a new model of care involving a public-private partnership of clinicians to improve the oral health and mental well-being of children affected by malocclusion in Southwestern Sydney LHD. Methods: this project is both innovative and unique in the sense that we are the first LHD to offer partnership with orthodontists in the private sector to help reduce waiting time for treatment for children affected with malocclusion. Invitations were sent by Oral Health Management to orthodontists within Southwestern Sydney Local Health District to participate on this project, and 3 orthodontists accepted the invitation to partner with us. A total of 130 patients on the orthodontic wait list were taken off the list to join the pilot program. Patients from the age of 16 and below, which is a holder of a current healthcare card and pension card, were assessed by the SWS clinicians to see if they are qualified to participate in this pilot program as per orthodontic treatment guidelines. 4 forms must be completed in relation to this project, signed by the district clinical director for approval and district officer with financial delegation to trigger commencement of treatment and installment payment for the treatment. All these forms are downloaded in the patient's file in Titanium, and item codes are used to reflect treatment provided by the orthodontist. Orthodontic referral and consultation form were completed by the referring clinicians. Agreed treatment plan and fees form completed and signed by the orthodontist and parent. Treatment progress report form is done by the orthodontist, which includes a summary of all treatment provided and relevant items, codes, and must be signed by the parent. And last is the treatment completion form, completed by the orthodontist upon fixed phase of treatment, and retain is issued and must be signed by parent. Results prior to orthodontic treatment. All children were interviewed during treatment consultation with clinicians, and most common problems identified by the patients were difficulty in eating and chewing, speech problem, low self-esteem and avoiding smiling, and difficulty socializing with other people. Result after commencement of treatment, all participants identified improvement in eating and chewing, can now speak clearly, started to smile more often, and now socializing with other people. Conclusion: A change is needed towards addressing malocclusion to maintain a healthier life and to reduce mental and self-esteem issues for affected children. The partnership within the Ministry of Health, Southwestern Sydney Local Health District Oral Health Services, orthodontist specialists in private sector is a great initiative addressing malocclusion. Through this project, will help ease the burden of the public system while simultaneously providing life-changing treatments to underprivileged children in the society. Thank you.
So I'm just going to change this presentation, open the other one there. Sorry. All right, welcome, Rebecca.
Hi, thanks everyone for having me. My name's Rebecca. I'm an occupational therapist, but one of those people who are very excited about oral health since working with a bunch of dentists and other oral health professionals. So I'm a project officer from the Communication for Safe Care project. The project team is a multidisciplinary allied health team made up of speech pathologists, OTs, and a physio. So are our oral health services communication accessible? And you may not have heard of that term before. It's a fairly new and unknown term. So communication access means that everyone can participate in their own healthcare, regardless of their preferred language, mode of communication, or presence of a communication disability. In 2015, there were 1.2 million Australians presenting with communication difficulties. And a communication disability can range from mild to severe and can include patients who have intellectual disability, neurological issues, for example, who have had a stroke, autism, developmental language disorders, or psychosocial disability. And we've heard a lot about those priority population groups today. Communication breakdowns are a key quality and safety issue, and research demonstrates that communication breakdown can result in errors, misdiagnosis, incorrect treatment, and poor care outcomes for patients. And as we heard Dr. Malik talk about, diagnostic overshadowing can also be another outcome. Healthcare workers often want to help patients with communication disability. They're passionate about helping patients, but they don't know how or are not confident to do so. Communication looks different for everyone. It's not a one-size-fits-all approach, and communication access needs to be individualized and person-centered. People with communication disabilities are likely to require modifications to the environment that you're working in, also adjustments to our behaviours to ensure access. So in healthcare, these are often called reasonable adjustments. Our project is a research collaboration between the University of Sydney, Western New South Wales LHD, and Southwest Sydney LHD. We've partnered with 2 sites here in Southwest Sydney, Oral Health Services, and also Campbelltown Emergency Department. And we've also partnered with 2 sites in Western New South Wales, the Oral Health Service there and Peri-Operative Service. We're really excited to have 2 oral health services on board so that we can compare a metropolitan outcome with the regional and rural aspect. Might see some famous faces here. We've been working with Southwest Sydney Oral Health Services to improve communication access through the co-design process. So we've been gathering information from patients and from staff about what is working well and what the barriers are for communication access. We'll be analysing these findings to seek to understand key themes and issues. We'll also be working together with staff and patients to develop solutions and improve communication access that's meaningful to the sites and services of this district. We'll then be evaluating our results. How are we understanding what the issues are and the barriers? We've completed our healthcare worker component. So we've collected surveys. We've been interviewing staff from all 4 sites, including our oral health service here in Southwest Sydney. And we're currently conducting interviews with consumers who have communication disabilities. We're asking them about what their experiences are accessing healthcare services and what they feel the major barriers are to getting dental care. as well as accessing an ED setting. We've been also conducting observations at different sites, and we've taken a bit of a roadshow to Yagoona, Bowral, Tamworth and Campbelltown. So we're quite familiar with many of the sites here in Southwest Sydney. And we've been watching dentists and dental assistants as they interact with patients in the chair. And we have speech pathology students who are conducting observations. One of the exciting outcomes so far has been developing what we've called the communication access observation tool. So we needed a way to capture what we were observing, to capture the good strategies and strengths and tips that, that the dentists and the staff are using with the patients. So this tool was actually developed in Oral Health Services in Southwest Sydney, and there's 3 components. So we're really looking at the communication access environment. How does the environment that you're working in the dental clinic inhibit or create opportunities to communicate with patients? We're looking at, the second component is looking at communication access between the patient and the healthcare worker. So what's the actual interaction look like? How is the clinician adapting or changing their communication so that the patient can really understand and participate in their care? And we're also looking at written resources. So is the information that we're giving to patients accessible? Can they follow the aftercare information when they get home? We're really excited about trialing this in our other 3 sites. So this is known as a universal precautions approach. So we're taking a universal precautions approach because we can't predict a person's communication needs just by looking at them. One person with autism may have very different communication needs to another person with autism. So we really want to be able to understand what the needs of the person are by asking them when they come into the service. And we're hoping this tool will be able to roll out nationally to help other health services become more communication accessible. Thank you.
All right, thank you. So our last presentation for the session is by Associate Professor, yeah, as I was saying, the last presentation is by Associate Professor Ravi Srinivas and Nathan Jones, and it's about improving the oral health of the Aboriginal community in Southwestern Sydney Local District. Welcome.
Morning all. So I'm Nathan Jones. I'm the Director of Aboriginal Health here at Southwest Sydney Local Health District. For us, it's always very important to make sure that we provide the right cultural context. I just want to acknowledge today that we're on Darrell land. Acknowledge the traditional owners, pay my respects to elders past and present, and extend that respect to everybody here today. It's also important to note that Southwest Sydney works across the boundaries of 3 traditional Aboriginal nations. So in our northern area, it's the Darug, in the Campbelltown Macarthur, it's the Darrell people, and then further south in the Wingecarribee, it's the Gundungurra. There are over 21,000 Aboriginal people in our region. It's the largest metropolitan population for a local health district of Aboriginal people. We've got several large communities across our region, with the most significant in terms of size being in Campbelltown and Liverpool. For us, a lot of our work is done collaboratively, and a lot of our work engaging with Aboriginal communities happens through working with our Aboriginal community-based organisations, of which there are 3 really significant ones in Southwest Sydney: Tharrell Aboriginal Medical Service based here in Campbelltown, Gundungurra Local Aboriginal Land Council in Liverpool, and Kari Aboriginal Resources Incorporated, which is primarily an out-of-home care provider based in Liverpool, but services all of Southwest Sydney and even parts of the state. So for us, Aboriginal Health and Oral Health have had a long-standing partnership. A lot of that's built around the fact that Ravi and I have been in our positions for extended periods. And early on in Ravi's tenure, he came and met with me and talked about Aboriginal health being a priority. The way that we drive a lot of our business and our collaboration is through our Aboriginal Oral Health Committee. So it's a partnership between the executive of the Oral Health Service and our Aboriginal Health team. It's got a few key focus areas. It looks at our mainstream oral health services and the opportunity to improve their cultural responsiveness and the way they meet the needs of their Aboriginal patients and families. We've also been able to develop a number of specific Aboriginal service models. There have been a number of initiatives as well to grow the Aboriginal workforce and Aboriginal workforce in oral health. And there's some research and evaluation, and we're going to talk about one particular project a little bit later. So for us, I feel like we've got a really nice base of innovative service models that have been developed over several years between Aboriginal and oral health. These models have all been developed collaboratively, and the focus has always been about making sure that the services are responsive to the specific needs of Aboriginal people and that they're accessible. And just some examples. So CARI, so that out-of-home care organisation I talked about, for many years we've had a dedicated clinic running out of Ingleburn on a fortnightly basis that prioritises kids who CARI have responsibility for. Happens every fortnight. There's a specific pathway where CARI caseworkers are able to identify the children, they're referred in, and we've got a dedicated team out there at Ingleburn who support those kids and their carers. Similarly, at Thurl Aboriginal Medical Service, we've got a number of dedicated paediatric referral pathways, particularly for those complex kids where the dental clinic at Thurl doesn't have capacity to service and needs some higher level of interventions. We've got a number of Aboriginal workforce initiatives. In particular, we've had a traineeship program operate for several years. That's resulted in a number of Aboriginal dental assistants being embedded in the service, and we're actually now working on a pathway to look at creating an Aboriginal identified senior dental assistant role within the service. A little further afield, down in the southern part of our region, we've got some dedicated Aboriginal oral health clinics at Wingecarribee and Wallandilly. They're really unique because there's not many Aboriginal specific services in that region, but we have a growing Aboriginal community. So those clinics are really important. And we've actually piloted a program where we've looked at a relaxed eligibility criteria for Aboriginal people in the Wingecarribee that's enabled different people that wouldn't normally be able to access these services receive care. And our latest venture has been setting up an Aboriginal oral health clinic at Ganagara in Liverpool that again is providing prioritised access to Aboriginal people who go through their services, and the referrals come by their general practitioners. I'm going to hand over to my friend Ravi to talk about the research.
So thanks, Nate. And look, it's a long-standing collaboration, I think over 10 years now, between Aboriginal Health and Oral Health Service. Thank you. So look, this is common knowledge. I'm just going to skim through this. Basically, we know that 50% of the kids' dental decay among its overrepresentation in Aboriginal children and also in patients who are pregnant mothers who are from Aboriginal backgrounds. 2%, 2 times more likely to be hospitalized for severe dental infections and problems. So among pregnant women, over 60% have dental problems, 30% will seek dental care, and 10% will receive oral health advice. And also the issue of waiting lists challenges that as well. So this work's been done. I'm just going to steal Professor George's thunder here, but there's a lot of work which was done with the Midwifery Initiative Oral Health Project, which started off in Campbelltown. And this led to a lot of guidelines around antenatal guidelines, which were successfully implemented. And I think now it's been implemented in other states as well, like in Victoria has also implemented it. This is another project which was done by Ariana Kong, who finished PhD from our service, from the program, rather, from the research program, the Greening Up Mums and Bubs project. Basically, it was a oral health model of care led by Aboriginal health workers for pregnant women. And as you can see, it's a cross-collaborative research. So really the process of the program was basically going through 3 phases. Looking at the phase 1 was the literature reviews, which is always a starting point for anyone doing a PhD or a master's. Really need to look at what the literature is telling us, the scoping of it. The second phase was looking at perspectives of oral health during pregnancy. Obviously, this is a qualitative study, so it's looking at 14 Aboriginal health staff as well as 12 Aboriginal women with the interviews. Then you actually develop the program, and then obviously the workshop comes after that to create resources. There's extensive consultation with Aboriginal health programs. It's very important to have very strong consultation. You can't consult enough. You have to make sure there's a lot of engagement, a lot more robust engagement than what you might probably think, and making sure that you know who the opinion leaders are, key leaders are. So obviously extensive consultation, then obviously the piloting of the program resources, priority referral pathways, and so forth. The HWs, which is the Aboriginal health workers, found the resources and program to be useful and to clinical practice and culturally appropriate, which is the most important thing. And the preliminary findings show that there's improvement of knowledge and confidence, because that's the health literacy part. This is all our fantastic staff there. The first person is Ariana, whose project is publications. We're happy to send this out to people. There's quite a few coming out across. That's Quality Award 21 during COVID. And I click this or click this.
So for me as an Aboriginal health worker, it gave me confidence to give resources and education to Aboriginal women on their dental health care, to dispel some of those myths around dental care, oral care, and encourage and support their journey to dental health. I made it part of my practice, so I spoke to every single woman about dental health and shared the resources when I could. So I just embedded it into my practice. It was a better way, I thought, and the more confident I got using it and delivering it, I guess they felt okay about having a yarn about their dental health care.
Okay. So what are the priorities forward? So obviously Nate did touch upon that. We were looking at establishing a Aboriginal identified senior dental assistant position. We are in the process of going through the expressions of interest part, I think, but that's something which will be coming soon. We're looking at eligibility criteria pilot. Obviously, we want to review the eligibility criteria pilot we're doing in Winji, Caribbee, and Wallandilly to see what the impacts are on accessibility for other patients. But that's something we want to focus on, especially the Aboriginal chronic care program, which is important. We're also looking at establishing their outreach program. We used to have kind of fell off the way during COVID, but we want to stand it up again with Harawal AMS. So that's really it. I'm open to any questions from anybody. Thank you, Robert.
Thank you. Thank you. Thank you. Could I get all the presenters to come down, please? Nathan, do you mind? We can ask you some questions. So we'll try and get through this quickly because I'm worried that we're running a bit over time. We have one more thing remaining, the workshop. All right, so I might just go with Sanjana. Obviously, your study was done overseas. Do you think, I guess, from what you're seeing in Southwest Sydney, that we need to do a bit more in terms of our clinical practice here, in terms of what you're finding?
Thank you for the question, Dr. Ajish. Yes, definitely. Something that we can focus on that age group, like below 6 years. That's where we found the study quite relevant overseas. If you can tackle it early on, then it's really good, because then before the permanent dentition actually comes in the mouth, if we can tackle that disease, it would be really good. So definitely we would be looking at that as an option. Yeah.
Okay, great. Thank you. Any questions from the audience? Yep, over there.
Sure. That's a good point. That's a good point. Yeah. Look, the look, the whole point is around making sure that we are able to provide culturally appropriate care in a safe environment. That's the issue. That requires significant engagement from people who are involved in the program. The reason why Winji Caribbean program is running well is we got, Kelly Geimer, for example, just mentioned her because she's been involved in this from the start. She's very engaged around making sure that whole linkages happen. There's a lot of stuff happens which we can't see. So, for example, with the elders and linking up and talking to the patients and working those ways around. But happy to consider that. But
they're very supportive. Anything that improves access for our community is important. And you're right, Campbelltown is our largest population centre for Aboriginal people. And Thurl provides an amazing service, but there's also restrictions, particularly around things like confirmation of Aboriginality and also the capacity of their service. So, look, happy to have a yarn about anything that would improve access to oral health care.
Thank you. My question is to Eileen next. Eileen, how have you found the receptiveness of the private practitioners you've been engaging? And do you mind sharing how you actually got them on board?
Okay, we actually send invitations to the specialists around the Southwestern Sydney Local Health District, and 3 of them accepted the invitations. They're actually very well engaged in the project. So they send a report to us and continually supporting the project and continually having interaction with us.
So why do you think, and maybe Ravi could, why do you think so far no LHD has explored this aspect?
Can't speak for other people, you know what I mean? But look, I think it requires a lot of engagement. I think with the orthodontists especially, you can't just, what we found with the barriers initially was many of the orthodontists said, look, we don't want to be anywhere near New South Wales Health because you guys don't pay us on time. That's a good one, right? So we have to make sure that that whole confidence is built up. Again, the trust factor is a huge thing. And one of the things we discovered during this program was the people talking to the practice and booking the patients in, we had to handpick them, literally. Not able to just able to speak English is not what I'm talking about. It's more about the attitude and problem solving approach, because you have a wrong person there, whole relationships fall flat. So I think it is going to become a significant piece. I mean, I'm looking at the numbers with next year. I want to make it business as usual, but the problem is we have to make sure that we have the correct numbers, and then we kind of have it as the whole point was to demonstrate to the ministry that it's actually possible to do it.
Great. Okay, thank you. Next question is Rashida. Rashida, well, firstly, congratulations on doing your MPhil. It's always a challenge for clinicians to engage in higher degree. Do you have plans to take your topic further, and in terms of next steps?
I'm looking for a paper publication, and in the upcoming IADR, I'm doing a poster. So that is in the pipeline. Other than that, I think it is more of a reflection process for us as general dental officers of how to help these patients who are at disadvantage. So if at all I get to publish some papers around this and knock on the doors of tertiary hospitals to provide some residency programs, mini residency programs, I think that would be my achievement. Yeah.
Great, thank you. Last question, Rebecca. So obviously this project is part of a bigger program of research. What do you see as hopefully the end goal? Like, what would you like to achieve at the end of all this?
I think our big mission is really about communication access across all health services. I mean, there's a lot of requirements for physical access. So if you think about a health service, we know that we need ramps to make it accessible for people who might have mobility issues, but there's not a lot known about communication access and how important it is for our everyday tasks of consenting patients and explaining treatment. So our project would love to see every clinician, no matter whether you're a dentist, doctor or nurse, using accessible language and providing patients with information in an accessible way that they can understand and respond to.
Great.
So that's a big goal, but I think it's a movement, so that the more we talk about it and the more we provide support to clinicians to do it in their everyday work, the more the vision will take off. So
Great.
Great question. Thank you.
Thank you. Well, please join me in congratulating the speakers. All right, guys. So yeah, you can go. We've got one more last workshop, which is my workshop, and I'm going to really rush through it because I know we're over time. Just bear with me while I start the. For those of you in the room, if you can please locate that one pager with a QR code that was given to you. All right. Just double checking, guys online can see the slide that's been shared. Oh, sorry. Wait. Sorry. Can you guys see that slide? The first slide? Anyone? Sorry. You can see that slide. Can you just verify that? You can see it. Yep. All right. So this is going to be an activity where I'd like everyone to start engaging. Hopefully, you've got that one pager, and the guys online, I'll share with you the QR code. But today is really about just seeing how we could explore supporting research culture in our district. All right. Now, we've said oral health services, but there are quite a few people in other services there. But as a clinician, it'd be good to get your reflection on what are things we could do. So what exactly? Come on. We're going to break up this workshop into a few activities. So first is an icebreaker activity where I'm going to get you to start using that software that I'm going to share with you to just get a sense of how many people are participating in this workshop. I'm going to go through quality improvement and research projects, look at what are the challenges for you to engage in such projects, and then identify potential supportive strategies to support clinicians, because the hardest thing is for clinicians to engage in QI projects and research projects, right? So the first thing I'd like to get you to do is scan that QR code on your screen, everyone online. And if your phone doesn't have that facility, just go to www.menti.com and enter that code. You should then see this slide on your phones. All right, so I'm going to go through a series of questions, and I'd love everyone to please provide your input. This is completely anonymous. All right, we won't know who you are. Right, we won't know what your phone number is. We can't track you down if you do say some horrible comments. But you know, I'm just trying to get everyone to be involved, particularly everyone online, because it is important to get everyone's perspective, whether you are a student, whether you are a clinician, whether you're working in admin, right, in this space. So let's start off with the first thing. Oh, people already entered. All right. So in what discipline do you work or study? So I'll give you a few minutes to answer that. So as expected, we have obviously a focus on oral health, which is there, but we've got few nurses, allied health. I don't think you can be anonymous with that one, and public health. All right, great, thank you for that. Oh, it's still going, okay. All right, let me go to the next question. What is your current role? So as a clinician or assistant, admin, manager, director, policymaker, academic, students? Okay, so we're getting a mix. So we've got policy, sorry, got manager, we've got assistants, and we've got obviously the bulk as clinicians. Awesome. And the students are there. Perfect. All right. Quick question. Are quality improvement or QI projects and research projects important for clinical practice? It's very encouraging to hear that it's only one bar there. That's very good. All right. Next question. Now, this is where you need to put phrases, and you don't have to fill all the 5 options. From your perspective, mention why do you think QI and research projects are important? There's obviously a character limit in each of those, but if you only think of one, that's fine, just submit, or you can put all 5. So as you can see, the ones that are bigger are the ones that majority are putting in. So changing clinical practice, which is great, education, innovation, better patient care. And there's obviously a whole bunch of others around the way. So that's really good that you've got, all of you guys are really highlighting those key responses there. Improvement is there as well. That's also great. You know, there's obviously a lot of benefits for QI and research projects. You know, and if you look at the literature, you know, it's all, and these things you probably know about, is really improving the care, coordination, and efficiency. Really trying to improve, maximizing the quality of care that is provided, and in certain instances, trying to reduce medical errors. So really trying to find, particularly from a research point of view, the most effective ways to organize, deliver, and finance healthcare systems. So overall, really, you're trying to improve clinicians' practices, improve patient outcomes, and improve the performance of systems. So really, you can't really run away from QI projects and research. It is integral part of clinical practice. Do you know the difference between QI and research projects? Okay, so we can clearly see there are some people on the fence, some people not too sure about what the difference is, but the majority do know. So just to refresh the memories of those that do know, and for those that don't know, here are some of the differences. So obviously, with QI projects, you are really trying to just improve the practice or processes within your institution. You know, you're trying to make sure that everyone is performing to a set standard that'll be out there. Whereas in research, you are really looking at developing new knowledge or contributing to existing body of knowledge. When you're actually doing a QI project, it's very flexible. You know, it's a very flexible process where you may go back and change the way you are doing the project, right? It can be systematic. When I say systematic, you know, every step informs the next step. And very often you would have heard the PDSA cycle, like, you know, plan, do, study, and analyze. So it's a very cyclic process. With research, though, it is very rigid. You know, you have a protocol in place, you say, I'm going to do this, and that's what you do. You don't go back and change, right? It is definitely very systematic. Every step informs the next step. In terms of the mandate, you know, so very often, and all of you have heard of it, most organizations ask you to be part of QI projects to improve practice. They may not necessarily mandate you doing research projects. You know, that comes from the university where, in terms of impact on practice, with QI project, there's always a direct impact. You know, that's why you're doing it. You're trying to improve practice within your service. Whereas in research, you may not have that direct impact straight away. It may be a bit later on. Okay, so it may not be something that happens straight away. It may require a few more steps, a few more research studies to inform practice. And that leads into the next one, where with a QI project, you're doing this to have a direct benefit to the processes that you're following or protocols or programs within your institution. Whereas with research, again, because of the delayed impact, it may not benefit the participants straight away. A big difference is with QI projects, there's no real risk to participants. When I say risk, psychological, could be physical. Whereas with research, certain things may trigger. For example, there are projects here where they looked at mental health. If you're doing interviews with participants with mental health, you may trigger some, psychological distress. So that's a big thing. And that's why with all research projects, you need to get ethics approval. Not all QI projects need ethics approval. In terms of analysis with research, you're doing more complex analysis. You're trying to find statistical significance. So you heard the p-value. Sanjana mentioned the p-value there, right? Versus with analysis for QI, you're really comparing with the standard norm. Like, are we meeting the standards? You're not going to too much complex analysis. Is the systems following the best standards? And the last one is, I guess, in terms of dissemination, you don't really plan at the start of a QI project to present at a conference or publish it, right? Whereas with research, you really want to do that consistently because you want other people to know about it. And it's important then with QI projects, very often where you present is within your organization. You don't really go. If you want to present over, to the external stakeholders, you need to get ethics approval. So this is just some of the differences between the two. Questions for you. Have you participated in any QI or research projects in the past or currently? It's great to hear that some have. Okay. So what 50-50? Some of you have, some of you haven't. What do you think for a clinician are the challenges to engage in a QI or research project? So I can see a big one is time. So you've got time there, you've got funding, you've got capacity, you've got support. Okay, there's resources in between, limited knowledge, support from the workplace. It's coming up there. Mentorship. Okay, so time is at the core of it, and that's no surprise. I mean, as clinicians, and it doesn't have to be the dental workforce, even the nursing workforce. I guess the difference with the nursing workforce, though, you do have certain, like the clinical nurse consultants, they actually have research as part of their KPIs and as part of their job description, right? So thank you for sharing that. That's actually really good. And all this is going to be very useful for future planning because I think Ravi's not here, but I mean, in the strategic plan, there are strategies, hopeful strategies to try and start engaging clinicians more in QI and research projects. What do you think? This is your wish list, all right? What strategies could support clinicians to engage in QI and research projects? So more targeted strategies. So we can combine more time, allocated time, and just time together into a big time. Mentorship, okay. Management support. Training, okay. Active engagement. Okay, so Support, allocated time, mentorship, training are the big ones there. In between, I can see some CPD work days, introduction to topics, access to research experts. All right, that's good. All right, let's go to this one. We're nearing the end. I'd like you to rank your preference. There's some potential strategies out there. I'd like you to rate on from 1 to 6, which one is most important for you? So quarantine time, obviously it's self-explanatory, but you know, it's about, okay. Right. So I think this is really giving a good picture of the key things. So obviously training is a big one. And it's not just training, it's training tailored to oral health staff, right? Time obviously is a big one, but you've got access to mentors and research expertise, all right? So that's an interesting one. I didn't think it would go up that high. Being part of projects led by staff specialists is also up there. Local champions for initial contact and guidance is one, and then opportunities to present at conferences. I think one of the things I've been, Robbie's not here, but is around really knowing who your local contact is to, if you want to start engaging in a QI project. You know, and I think Robbie is happy for me to share, but I think he wants to potentially have a local champion at the different clinics, and then that local champion leads into your quality manager in the district in terms of ideas for this. The other thing is, so we're actually doing that. Our center's doing it at Sydney LHD. Over the last 4 months, we've been starting a monthly research training workshop at Sydney Dental Hospital, online workshop, and also face-to-face across various research and QI topics. You know, starting off with how do you conceptualize an idea? How do you review the literature? You know, all that stuff. So, but that was based on a survey that was done among all the dental practitioners and dental assistants to identify their key priorities. So maybe that's something we could explore here. Quarantine time, obviously, that's dependent on the senior management for that. Access to mentors and research expertise. Again, we can discuss that in the next slide where I'm going to open the floor, but is that access to mentors within your service, or is it outside academics, or being part of links to academics who could help you with certain topics is also a potential there for that. So I'd like to open the floor to, we're 3 minutes over, and I promise you we're almost done. To everyone, including everyone online, I'd like you to share with me any thoughts from what we've done. From your perspective, what do you think would be really supportive? And maybe elaborate on these points here. You know, oops, sorry, the one that you, these, if you want to elaborate on some of these things that you've just mentioned. Anyone? All right, let me then ask you, access to mentors and research expertise, what do you want from that? How would that work? Do I need to be anonymous for that one as well? Anyone online? No? So, okay, so can I say, so basically if there was some sort of online workshop or face-to-face across various topics that you decide, right? You'd be interested in something like that? Yep, okay. How would quarantine time work? I mean, it's nice to say that, but really, what are you looking at? Because I know as clinicians, for those that have done QI projects, how did you juggle it? Eileen? In between patients, right? So in the ideal world, I know Ravi's not here, but in the ideal world, how would that look if you wanted to have? Right, unmuted. Okay, right. And in terms of access to mentors and research experts, obviously you know that our centers at Ingham Institute, we have a whole suite of staff there who are experts in either qualitative, quantitative, or even just designing a project. You having access to them via email and then potentially setting up meetings if you've got quarantine time, is that something that you would be interested in? Yeah, okay. Is the biggest struggle for you is actually conceptualizing the idea and making sure that you're actually doing it in the right way to deliver the right results? I think, because I'm just reflecting on what's happened in the past with other clinicians. Do you have something to say? Any comments? No? Do you think having one of the things we're thinking of is having like a checklist of, so step one, this is what you need to do, and then having contacts, local contacts, right? It's almost like a screening process, because I think what is definitely quite clear is any projects that are being done need to show some benefit to the LHD, number one, and it needs to be aligned with the strategic plan for the state. That is the most important. You heard that this morning, right, from Kara. So that's a big focus, and Robbie is really pushing for that. And do you feel having opportunity to present in these kind of forums? I know the three guys that presented. Do you feel that it helped you? You're more confident the next time we tap you on the shoulder? Okay, all right. So more opportunities for that. All right. Okay. This is very useful. We're going to collect all this data, and I guess because it's really you guys are saying what you need in this space, and hopefully we come up with some sort of strategies, and we have more presentations from the clinicians next year. So on that note, I would like to conclude the Oral Health Showcase. Can I get you all to again, please give a big round of applause to all the presenters today for all their wonderful work. It is not easy to present your work in 5 minutes. All right. Even for seasoned academics and PhD students, very hard. So I commend the three clinicians for doing that. I would also like to thank the other members of the organizing committee, all mentioned there, particularly Rebecca, Ignivo, and Leanne, for supporting the back end, the photocopying. I know it was last minute, really making today a success, and thank God IT worked. It was so. I'd like to thank you all once again, and I hope you enjoy the rest of the Southwest Sydney Research Showcase for this week. Thank you all. Okay.